And our next doctor to chair and moderate this morning took his internal medicine residency at the Ilocos Training and Regional Medical Center, his fellowship training in rheumatology at UST Hospital. He is a member of the Asia Pacific League of Associations for Rheumatology and a Philippine representative in the APLAR Special Interest Group for myositis and scleroderma. Ladies and gentlemen, let's all welcome Dr. Joseph Patricio.
Good morning, everybody. Ang lamig, frostbite. Good day. It is my honor and privilege to present this esteemed rheumatologist from around the world, APLAR Fields, or even ACR. The first one needs no introduction. I think everybody knows her. She's the APLAR Master Awardee for 2021, Professor, Department of Medicine, University of Santo Tomas, Faculty of Medicine and Surgery, Chief Section of Rheumatology, UST Hospital, President and CEO, Rheumatology Educational Trust Foundation Incorporated, or RETFI, Director of Lupus Inspired Advocacy, or LUISA, and People Empowerment for Arthritis and Lupus Projects, Steering Committee member for Lupus Academy, founding member of Asia Pacific Lupus Collaboration, or APLC, founding member of Asian Lupus Network, ALNN, and medical consultant, UST Hospital and St. Luke's Medical Center. Ladies and gentlemen, let me present to you Dr. Sandra Teresa Victorio Navarra. So next in line, we have Dr. Leonid Zamora. He's a doctor of medicine from the University of Santo Tomas, Faculty of Medicine and Surgery. He had his fellowship in rheumatology also at the same hospital. Then he further had Masters of Science in Molecular Medicine at St. Luke's College of Medicine. And at present, he is an assistant professor of medicine at the UST Faculty of Medicine and Surgery, where he is also the assistant research head from the Department of Medicine. He is a research coordinator for Department of Medical Education and Research in the UST Hospital. He is a member of the Review and Ethics Board. He's a member of the APLAR Young Rheumatologists, Asia Pacific Lupus Collaboration, and PRA Ad Hoc Committee on Core Curriculum Development. He's an active consultant of the University of Santo Tomas Hospital. Let's all welcome Dr. Leonid Zamora. Our next speaker is from Indonesia. She had her residency in internal medicine and magisterial in Bandung, Indonesia. Fellowship of Rheumatology and Clinical Immunology from University of Santo Tomas Hospital, and had also research fellowship continued. He had her medical science doctoral degree at the University of Pajajaran in 2020. Currently, she is the Vice President of Indonesian Rheumatology Association and member of the Asia Pacific Lupus Collaboration. Co-opted member of APLAR EXCO and Scientific Committee and Lupus SIG member of APLAR. Currently, she's a consultant internal medicine department, Faculty of Medicine from the University of Pajajaran, Bandung, Indonesia. Let's all welcome Dr. Laniyati Hamijoyo. Okay, next, he is the head of the School of Clinical Science at Monash Health, clinical rheumatologist and head of the Monash Health Rheumatology Unit, and specializes in research and clinical care of systemic lupus erythematosus, complex rheumatic diseases, and rheumatoid arthritis. He's the founder of the Monash Lupus Clinic, which is the Australia's largest research-grounded clinic for patients with SLE, a founding member of the Australian Lupus Registry and Biobank, and chair of the Asia-Pacific Lupus Collaboration. Key interests of this next professor are the biomarker studies of SLE, clinical outcome measurements, and biological profiling in SLE, and the actions of glucocorticoid-induced proteins of the immune system. His group has pioneered for the development of treat-to-target outcome measures in SLE via the Asia-Pacific Lupus Collaboration, which has over 1,800 patients under study. His lab discovered the role in rheumatic disease of multiple important glucocorticoid-regulated proteins. Most recently, his group defined the role of GILZ in rheumatoid arthritis, Th17 pathways, B-cell activation, seems like I'm the speaker, and lupus, and are working on exploiting its action to develop a safe glucocorticoid mimic. His lab also works on innate immunity, including the actions of unique pro-inflammatory protein MIF. Advisory, expertise, and research collaboration. Experiences with international biotech and pharma companies include AstraZeneca, Janssen, BMS, UCB, Pfizer, and to name a few. Let's all welcome Professor Eric Morand. Thank you.
Good morning, everyone. Again, welcome to this Lupus Academy Roadshow at PRA 2023. So the Lupus Academy Roadshow is something that the Lupus Academy has advocated through the years. Aside from the annual Lupus Academy meetings that we have the Lupus Roadshow that is being held in different countries as adapted to their own cultures, as adapted to their own needs. And this is, the Lupus Academy is actually communicate, so the aims of Lupus Academy is to communicate, educate, and treat. And thank you very much, Dr. Patricia, for introducing the first part of this Lupus Academy Roadshow will be the plenary lectures. We have changed the order a bit, and we will have Professor Eric F. Morand to be the first speaker. He is joining us online. He is already online. And you have heard that Professor Morand is definitely the leading research organizer. He has led and spearheaded the leadership of the Asia-Pacific Lupus Collaboration. And it is truly a big thing for putting in focus the Asia-Pacific lupus collaboration that we have in many countries. And Dr. Laniati Hamijoy will talk more about the APLC because that is on research in SLE. And the head of that, the master of that, is actually Professor Eric Morand. So Professor Eric Morand will be speaking on treat to target, improving SLE outcomes. Before we go to Professor Morand, we hope every now and then I will be projecting this. Please feel free to ask your questions and post your questions on Slido. So you have the app, can easily be downloaded. You have the QR code there, and you have the website. So our fellows will be assisting, our technical staff will be assisting you to post any questions or comments on the Slido so we can have a very interactive session on this. So, Professor Morand, welcome to Baguio City.
Thank you very much, Sandra. Just check that you can hear me.
Yes.
Okay, thank you so much.
Thank you for joining us, Professor.
Thank you so much. I'll share my slide in a moment. I just want to first say hello to my friends and colleagues there at the PRA meeting. I'll be talking a little bit about work that we've done together in the Asia Pacific Lupus Collaboration, as well as some other work that addresses this topic. I wish I could be there with you in person, but maybe next time. And I want to thank the organisers for accommodating the slight change in schedule. The son of one of my best friends is getting married, so I needed to leave slightly early. But I look forward to your questions. I'm going to share my screen now. Before I begin, we have a tradition in Australia, which is to pay our respects to the First Nations peoples, traditional owners of the land and country that we join this meeting from, and pay respect to their elders past, present and emerging. So I'm going to be talking to this title that I was given, Treat to Target, Improving Lupus Outcomes. And I'll talk for 15 or so minutes, and I'll be happy to take questions right after that. These are my disclosures. And I want to begin by thanking the many people who've made all this work that we do possible. I'll talk in a moment about the amazing Asia Pacific Lupus Collaboration, but I want to thank the patients. Every patient teaches me something, and the thousands of patients that commit their time and data to our research teach us all something. We have a beautiful team of technical, scientific, and medical people on the clinical research team at Monash, as well as a fantastic lab team now led by Dr. Sarah Jones. Our funding comes from the Lupus Research Alliance, the National Health Medical Research Council of Australia, Ulysses Club, and other sources. So, why should we treat to target in lupus? I think we should all understand this, but I'm going to say it anyway. We all know that mortality from lupus got better in the last half of the 20th century with the introduction of better critical care, the breakthrough of cyclophosphamide to improve outcomes from lupus nephritis and CNS disease, and understanding of better use of steroids. However, this paper shows that in the first 20 years of this century, lupus mortality has not improved. On the left is a graph from a large study in the UK looking at mortality from 1999 to 2006 and from 2007 to 2014 in lupus patients. And you can see you can see there's no difference between those two time periods. In contrast, I'll just get my pointer here, and the mortality remains much higher than the mortality of the matched healthy control population. In contrast, in basically an identical study, but looking at rheumatoid arthritis in the same time period, mortality from rheumatoid arthritis massively improved in that same period of time and really approached the mortality of the normal population. So we still have patients dying of lupus at a rate that is unacceptable. We have looked at data in our Asia Pacific Lupus Collaboration data set. This analysis was done on 3,384 patients and over 30,000 visits of data. And we know what our goals of care are now. Our goal of care is to have low disease activity. For example, a time-adjusted mean SLEDAI less than 4. But 34% of our patients have a time-adjusted mean SLEDAI greater than 4, which effectively means that 1/3 of patients have active disease all the time. 25% of patients have an episode at least once of high disease activity, a SLEDAI of 10 or more. And 1/4 of patients never achieve the goal of low disease activity. I'll talk about low disease activity in more detail in a minute. Of course, these different states are somewhat overlapping, but when considered here against the outcomes, we can see that patients with an average disease activity above 4 are 36% more likely to achieve damage accrual and 236% more likely to die. If you ever have an episode of high disease activity, damage is increased by 1.8, mortality is increased by 5. And if you never achieve low disease activity, damage is greatly increased and mortality is greatly increased. On the bottom of this graph is shown other bad outcome measures, including greater exposure to steroids and worse health-related quality of life measured with the SF-36. So too many patients, even in these excellent Asia-Pacific lupus academic centres, are achieving unacceptable outcomes, and those outcomes are associated with very poor prognosis. Part of the reason for that is our current treatments are not good enough. These are data also from the Asia-Pacific Lupus Collaboration, looking at treatment survival. So not patient survival, but treatment survival. So at baseline, if you're on prednisolone, the probability of still being on prednisolone 3 years later is 75%. Well, that's bad. We don't want patients to stay on prednisolone. Hydroxychloroquine is shown here. The probability of staying on hydroxychloroquine at 3 years is also 75%. Okay, that's good. We want patients to stay on hydroxychloroquine, but I'd prefer it to be 100%. In contrast, these two commonly used immunosuppressive drugs have short treatment persistence. So by 3 years, only about half the patients who start azathioprine are still taking it. And for mycophenolate mofetil, by 3 years, less than half of patients who started are still taking it. It was slightly better for mycophenolate sodium, which is slightly better tolerated. But these mainstream immunosuppressive drugs, which we think patients need to take for a long period of time, actually patients can't take them for long periods of time. And treatment persistence is a surrogate for the combination of efficacy and tolerability as judged by the physician and their patient in the clinic. So we have to do better. And what we need to do is adopt the treat-to-target approach that's been so successfully used in cardiovascular disease, diabetes, and of course also, as we all know, in rheumatoid arthritis. So many papers were published in about 8, 9, 10 years ago, recommending a body of work to determine how to treat to target in SLE. There was a treat to target international task force that several of us were involved in. And we also wrote this paper in Nature Reviews Rheumatology, where we proposed how we would get to a treat to target endpoint. And in this paper, we concluded that treat to target endpoints must include disease activity and a disease activity state that must be attainable. And disease and treat to target endpoints must also include consideration of treatment, especially steroids. I'm going to explain why that is in just a moment. That's different to treat to target in rheumatoid, for example, where we don't count the treatment as part of the target. And treat to target endpoints also used to have utility. They must be feasible, measurable, and attainable, and they should also have validity. We have to prove that such outcomes can be associated with improved long-term outcomes for patients. Why should we include disease activity and steroids in an outcome measure for lupus? Many papers have shown that steroids contribute to cumulative harm to lupus patients over time. This is one such study, again done in the Asia-Pacific Lupus Collaboration, showing basically the risk factors for damage accrual in 1,707 patients followed for 2 years. Now, some things we can't change. We can't change your race. We can't change your age, though some of us would quite like to. And we can't change your baseline damage. What can we change? Disease activity and steroid. And this forest plot shows that the size of the effect on damage risk for disease activity measured by PGA or SLEDAI is the same size effect as the effect on damage of taking steroid. And this is after multivariable adjustment, because obviously there is some confounding between disease activity and steroid dose. So 1 point on the SLEDAI has a risk of damage that looks like this. 1 milligram per day of steroid per 1 milligram, the damage risk looks like this. So it's absolutely clear that to improve outcome for lupus patients, we have to lower disease activity and we have to lower steroids. We've just published this paper also using data from the Asia-Pacific Lupus Collaboration, looking not at damage, but at mortality. We looked at risk factors for mortality across this large cohort of patients, 4,000 patients actually. And we found that disease activity measured with SLEDAI or disease activity measured with physician global assessment and corticosteroid dose in milligram were independent risk factors for mortality. 1 milligram of steroid per day has an 18% increased risk of mortality. 1 point on the SLEDAI has a 17% increased risk of mortality. These are amazing figures. This also shows that smoking is a risk factor for death in lupus patients. And very importantly, in our part of the world, if you live in a country with a GDP per head of population less than $20,000, it's also highly associated with mortality. So as we think about addressing mortality and outcomes in lupus, we have to think about our region and the special needs of patients in middle and lower income countries. So to cut to the chase, we've now done huge amounts of work to define low disease activity and remission for lupus. So low disease activity is defined as a SLEDAI of less than or equal to 4, excluding any points for major organ involvement. So we do allow some disease activity. Therefore, none of that disease activity should be new, because if you've got new disease activity, your lupus is unstable. We include a measurement of the physician global assessment because the SLEDAI is not a perfect instrument. And we capture a ceiling dose of prednisolone of 7.5 milligrams. That's not to say that 7.5 milligrams is the target, but to say that more than 7.5 milligrams is unacceptable for low disease activity. On the right in green, you can see the DORIS remission definition, and it's deliberately more stringent. The clinical SLEDAI must be 0, so you could have serological activity but no clinical activity. The physician global assessment of less than 0.5 and a prednisolone dose of less than or equal to 5 milligram. So you can see these two stages are related to each other in the way that they're captured and measured, and one is more stringent than the other. So now I want to show this picture mapping the Asia-Pacific Lupus Collaboration, all our incredible centres across the region, including here in the Philippines, Indonesia. The next two speakers are both important collaborators of this collaboration, as is Professor Navarro, who's on our executive committee. So we showed in this study published in Lancet Rheumatology 3 years ago that attainment of low disease activity is protective from flare and damage. On the left is shown the rates of flare in people who spend half their time in low disease activity compared to people who spend less than half of their time. And there's a massive reduction in the rate of flare. And on the right shows the accrual of damage measured prospectively over time in these patients, and 50% of time in low disease activity is associated with a 50% reduction in the risk of organ damage. There are many, many other findings in this study, but in the interest of time, I'm keeping this fairly high level. But damage is not all we should care about. Patients' main concerns are about their health-related quality of life. And so measured with the SF36, here we showed analysis cross-sectionally in 1,422 patients that being in low disease activity is associated with better health-related quality of life in multiple physical and mental health domains. We're currently analysing the longitudinal outcomes of health-related quality of life in relation to low disease activity attainment. Now, to use new drugs to get people into low disease activity could be expensive. But we've also shown that being in low disease activity saves money. In this study in our centre in Melbourne, Australia, in 200 patients, we showed that if you spend 50% or more of your time in low disease activity, the direct healthcare costs are reduced by 26%. I think these data are the sorts of things we need to use when we're talking to insurance companies, payers and governments and hospitals about access to drugs that could be expensive, because they will save money by keeping people healthier. It's also emerging that it's important to attain low disease activity quickly. There's several studies now. This is a beautiful one from our Japanese colleagues that showed that if you attain low disease activity within 12 months of diagnosis, your outcomes are greatly improved. And finally, in our mortality paper, we looked at the association of low disease activity with protection from death. And this heat map shows every patient in the study. There's nearly 4,000 of them. In green is time in low disease activity. In red is time not in low disease activity. So about a quarter of patients were in low disease activity all the time. A quarter of patients were never in low disease activity, as I said before, and 50% of patients were in and out of low disease activity. And so these patients are ranked according to how much time they spent in low disease activity. And sadly, I have to tell you that every black dot on this figure is a death. And you can see that the deaths have fallen to the bottom of this graph. Deaths are more likely in people who did not spend time in low disease activity. Now, let's just talk about low disease activity and remission. These are data from the belimumab BLISS phase 3 trials, one of which, as you know, was led by our own Professor Navarra, that led to the registration approval of this drug. Post hoc analysis has been done by a few groups looking at low disease activity and remission in these patients. And if we look at the top of the graph, which is at week 52, when the highest number of patients were in lupus low disease activity state, or LLDAS, that's the proportion of patients in LLDAS, about 16%. In blue are shown the patients who attained DORIS remission. That's about 8%, or roughly half. And very importantly, what that means is that half the patients in low disease activity were also in remission. That makes sense. Because LDAS is a ceiling state and remission is more stringent than that. But half the patients in low disease activity were not in remission. They were in low disease activity, but not yet in remission. So these states are concentric, but they are not redundant. They describe different states, and that's very helpful information to us. Now, quite a few years ago now, Michelle Petrie analysed the early definitions of low disease activity and remission in the Hopkins cohort, and found something very important that's been shown several other times since. When we look at the risk of organ damage accrual, we can see that being in low disease activity for 50% of the time, shown in yellow, more than 50% of the time, reduces damage by about 50%. 50% of time, 50% reduction. The same degree of protection is seen with attainment of remission, but you can see that protection with less time in remission compared to how much time it takes in low disease activity to get that protection. Again, telling us that remission is usefully more stringent and better state of control than low disease activity, just as we hoped when we designed these measures. The same is true for health-related quality of life. This is looking at remission in the top half and low disease activity in the bottom half. Suffice to say that both are protective in terms of health-related quality of life, measured with ASF36 physical and mental component scores. But you need less time in remission to get this benefit than you do in low disease activity. Again, consistent with this difference. Now, we did look at mortality in these data, and we could not find that remission was more protective than low disease activity from mortality, unless we changed the steroid dose associated with remission and more stringent steroid thresholds, lower than 5 milligram or even down to 0, were associated with stepwise improvements in protection from mortality. And I think future definitions of remission should potentially have a more stringent steroid cutoff, potentially even 0. Okay. So how can we get our patients into these target states? Better use of what we have now and new, better medicines. Evidence that we can get there with drugs we have now is available in a few studies. This is a beautiful randomized controlled study, open label, comparing mycophenolate mofetil to azathioprine for people with active non-renal lupus. And these are data, I made the graph, the data are in a table in this paper, and it shows that low disease activity attainment is superior for mycophenolate than for azathioprine. That same was shown for remission. So when we have a patient with active non-renal lupus, if we have a choice between mycophenolate and azathioprine, these data would suggest that mycophenolate is more likely to get you into low disease activity and remission. So we should probably choose it. The same was shown in a study of childhood lupus. It's a smaller study because it's a more rare disease, but this showed that early introduction of mycophenolate in children with active lupus was strongly associated with a higher likelihood of attaining low disease activity by 6 months. What about our new drugs? I talked before about these BLISS studies, and this shows that low disease activity was achieved in more patients treated with belimumab than patients treated with placebo in both BLISS 52 and BLISS 76, with odd ratios of about 2. So if you're on belimumab compared to placebo, in addition to standard of care, you're twice as likely to get into low disease activity. Remission rates were not superior for belimumab in the analysis of these data. Most recently, this phase 2 study of deucravacitinib, a novel TYK2 kinase inhibitor, used as one of its key secondary endpoints attainment of low disease activity, and being on deucravacitinib made you 4 times more likely to achieve low disease activity after 1 year of treatment compared to placebo. This is a massive signal that these advanced therapies have the ability to get our patients into target states. And most recently, this paper just came out in Annals of Rheumatic Disease, looking at attainment of low disease activity on the left and remission on the right, with anifrolumab compared to placebo and post-hoc analysis of the TULIP studies. 30% of patients got into low disease activity with anifrolumab, and about 12% got into remission. So it looks as though our more advanced therapies improve the chances of getting into low disease activity and remission. And I think it's where we need to go. So can we get patients to target and improve their outcomes? Yes, we can. Thank you very much for listening and for the invitation to be with you today. I look forward to taking any questions while I'm here.
Thank you very much. Wow. Hello, Eric. Can you see me?
I can hear you.
And you can hear. Okay, thank you so much. And that was so elegant, very simple. At the Philippine Rheumatology Association, we have our trainees. We have definitely a different setup than what you have in Monash University. So we have a lot of clinicians who see their own patients. Would you encourage them to pull together the data so we can see it in our own group, among our own patients? So for these patients, for our own patients in the Philippines, how can we apply the treat to target strategies, especially the LLDAS?
Yeah, I think what we have to do first is change our thinking. We've all been treating lupus patients for a long time, and I think we've grown used to patients doing badly. We've almost psychologically adapted across our careers to the idea that lupus patients will have bad outcomes, stuck on steroids, low quality of life, not working, early death. I think we need to change how we think about it. We need to see that this is something that we have the ability to change. And with our patients, we should change our thinking about being more aggressive, just like we did with the treatment of rheumatoid arthritis 25 years ago. Sandra, you and I are old enough to remember once upon a time, we didn't treat rheumatoid very aggressively either, but we do now. And it makes a difference. So the first change is in our mindset. The second is to use the available drugs like mycophenolate and lobby with our payers and governments and insurance companies to give access to the more advanced therapies so we can help our patients. So I think it's a mindset change, and then we need to implement it.
Thank you, Eric. That was great. That's very good advice for all of us, especially with the Philippine Rheumatology Association. For us coming here together, we need to have our minds together and have a mindset for attaining for each patient. So it's not just putting one patient, treating this patient in the clinic and making decisions on one patient. We just need to get our act together. Thank you so much, Eric, for encouraging us on that. There's one question on Slido from Dr. Villamin. How long and at what dose should MMF be maintained in order to sustain LDA, low disease activity, among patients with non-renal lupus?
It's a very good question, and I don't know the answer in terms of data. It's a question that we should look at in our data, because with the help of our regional colleagues, we do have a huge amount of data now. But we don't know when you should stop or taper the therapy. I feel like even with our biological therapies, they're not even yet on the market. People are asking me, when should I stop them? And my answer is, it's the wrong question. How can I start them is the question that I want to ask. So our normal practice in non-renal lupus, if a patient is in remission for more than 2 years, we will consider tapering therapy. But unless they're already tapered steroid to below 5 milligram, I would not be planning to taper or stop their mycophenolate. It's the steroid that we have to reduce or get rid of. And unfortunately, we know that with our current therapies, when we stop steroid, there is a risk of flare, even when you continue to take background therapy. So I'm tending more and more to leave patients on therapy long term.
Thank you. Thank you for that. There's another question here on Slido. You mentioned about attaining SLE or lupus low disease activity using azathioprine and MMF. Would you have an idea of what type of patients in terms of clinical profile benefit more from azathioprine versus MMF?
I used to think that I knew the answer to that question, and now I think I don't. Obviously, the data in lupus nephritis are extremely strong that mycophenolate is superior to azathioprine and equivalent to cyclophosphamide for induction and also for maintenance. For non-nephritis, I think the quality of the data we have around different organ manifestations and actually the way that we measure that with something like SLEDAI is quite poor at informing us which manifestations are most likely to respond. The aggregate data suggests that mycophenolate is superior overall, but I don't have a strong feeling about which patient would be better not to use mycophenolate but to use azathioprine. And maybe that's the way we should frame the question, assuming you have availability to both drugs. When should you not use mycophenolate? I would say prove to me that azathioprine is better for that patient. I don't think there's any evidence for that. We use methotrexate often to treat arthritis in lupus patients. Not that much evidence for that either. We do it because we're rheumatologists and we're familiar with using methotrexate to treat arthropathies. Of course, it does work sometimes too. But I think we need to get better at addressing the question that your questioner has raised.
Yes, and it all goes to the bottom line. You have to personalize and individualize your treatment for each patient. But
Absolutely.
you do have strong data there already that especially for induction and maintenance, you still have a superiority of mycophenolate mofetil over azathioprine. But it just says superiority. You certainly, we know that we're clinicians here, it just says superiority, but the data that we have, the results that we have are just there for us to guide us for each patient. There's another question, is there a recommended frequency of monitoring? I think this is very, very nice, especially for our setting. Is there a recommended frequency of monitoring to see if T2T or treat to target is achieved? Is it every 3 months or every 6 months?
Yeah. So the EULAR treatment guidelines recommend the patients be seen every 3 months. And that's our practice in Monash as well, unless the patient's been in long-term remission, in which case we'll see them less often. So we think of 3 months as sort of a baseline for routine follow-up. It makes sense actually for monitoring the safety of medications too. We want to see the patient's blood tests. If they're on mycophenolate, azathioprine, cyclophosphamide, we need to see their full blood count, liver function, and so on. And as across the years, we need to talk to people about their cardiovascular risk factors, their osteoporosis, their vaccinations. So seeing people often enough to be able to cover all those other things too, I think every 3 months should be the baseline. We're lucky in our centre, we can see patients as often as we need to. So we're able to, in some patients, see them every week if that's what we need to do to keep them out of hospital. So we're very fortunate in our situation that we can see patients more often when we need to, and we do that to try to stop admitting them to hospital. But yeah, in answer to your question, I would say 3 months.
Thank you. In general, 3 months. And would you say that patients who have more active disease may need to be seen more frequently?
Yes.
Monitored more frequently, whereas those who have gone into LL-DAS for a long period of time and can be maybe every 6 months?
Yeah, that roughly I would say that's true. Yeah.
Okay, are there any more questions? We have eaten up 30 minutes of your time. Professor Eric Moran, thank you so much for this morning. We'll let you go now, and we wish you a great weekend, a happy weekend. Thank you. Thank you
very much. Thanks for the invitation. It's a pleasure to see you. Bye-bye.
Thank you. Bye-bye. Also, again, to remind you, please post your questions on Slido. For those who may want to use the microphone, yes, please, you are most welcome to use the microphone. But let's make this more interactive. We want to know your thoughts. You can even post your comments on Slido. You have the app there and just say it's anonymous. It's fine. I can always screen whatever comments you may have in there and read it out here. So please, we encourage you to use your Slido for your questions, any questions or even comments. Again, thank you for that. And let's now move into our next speaker. We have our Filipino, adopted Indonesian, who is now really Filipino. He can speak very good Tagalog. She can speak very good Tagalog. We are building bridges in lupus research, the Bandung experience, which is now very close to what we have in the Philippine setting. We have Dr. Laniati Hamidjoyo from Indonesia.
Thank you very much, Dr. Navarra. I would like to thank PRA and also the scientific committee to have me talk this morning. So the task assigned to me is about the building bridges in lupus research. So I would like to start. This is, I have no disclosure. This is my outline. As you know that lupus has involved many organs, starting from the top of the hair until the tooth, and it's caused so many, involved many disciplines, so we can collaborate together to the research. So as students here, or also the teacher or clinician, so what we can do to our patients, that's the question that we start our lupus research. I would like to show you this very, not so old systemic review, epidemiology of the systemic lupus in Asia Pacific region, done by several, very famous lupus scientists in Asia Pacific country. And it shows here that when you have the diagnosis of lupus, the most manifestation is arthritis and also the malaras. But during the cumulative, and you can see here, it's arthritis is still higher, as well as the malaras, but renal also involved in the lupus manifestation. So, however, if we can see here, the small letter here, the China, Korea, even Philippines, but there is no Indonesia. So that's why I would like to involve Indonesian patients to the manifestation of lupus. So that's why after finish my training in USD, I returned to Indonesia, then start to build the backbone of our lupus study. So we name it Hasan Sadikin Lupus Registry. It's the name of my hospital in Bandung. So I started in 2008 until 2013. We have already around 400 patients. And our mission is, we would like to have our patient in better quality of life. However, it's very difficult to build a registry. Maybe you have your own here. That's sometimes patient cannot afford to check their complement. It's very expensive, in my country also, it's very expensive, as well as the antibody, like anti-dsDNA. In every study, we need SLEDAI as a disease activity measurement, as a standard, but it's very difficult. So that's why we need the collaboration. Luckily, in year 2013, I was invited by Dr. Navarra, involved into the LLDAS Asia Pacific Lupus Collaboration, as mentioned by Professor Eric a while ago. So we set up the definition of LLDAS at the time, which you have seen by Professor Eric a while ago. So this is the APLC, and now it's involved many countries, including UST and as well as PGH by Professor Michael T. Then we have done this, like a momental definition of the LLDAS, and now is sitting by many papers about this target of therapy, the LLDAS. So as Professor Ek mentioned a while ago, that this is already proof that if your patient put into the LLDAS condition, then they have the good quality of life compared with the non-LLDAS. So we try to put our patient in the LLDAS situation. So this is the last, our team in 2019, we set up the development of the APLC cohort. So back then, I returned to my own place. Then I built, together with my colleague, the Bandung Lupus Study Group. It consists of the students, even consultant, and who the ones still on study for their master degree or PhD or even resident, and also the fellow. Because in our country, if you are a student, you must have one research done, even not get published, but you have the research done before you can graduate it. So they need to do some study. So that's important. So that's why I promote this like a lupus registry, so everyone can come and join, and they can also do their own study. So we have meeting every Thursday. I dedicate a time to listen. Some of them come with a proposal of the lupus study, any kind of the lupus study, so they can come and then join. If they need funding, then we try to look for that funding for them. So by the time we have built this registry comes, and then some students come with the genetic study, other with the registry or epidemiology study, and the other with comorbid, and many kind of study comes along with this registry. I would like to show you, this is my student Dan. They did some very simple study about what is the manifestation of the lupus, mucocutaneous lupus. So maybe it's the simple study, but it can show how is the characteristic of lupus in my country, because I told you a while ago there is no paper comes out from Indonesia. So this paper published even in local, but it's show what kind of lupus in my country. So one of the other students make a simple study about the memory involved, the memory problem in our lupus patient. Even very simple, they do the memory recall, and they found out that our lupus patient has a lot of problem with the memory recall. And the other one, this is young student from Malaysia. She did the outcome of pregnancy in our lupus cohort. So it's also very nice to know that our lupus patient has problem with the pregnancy. So after that, we did publish our lupus set cohort. This is published in Lupus Journal 2019 about the characteristic of our lupus in Indonesia. I show you, this is our lupus is around 800 patients, but most of them is female. And the most manifestations is arthritis and malar, almost the same as other country, but I show you when they diagnose, they have around 40% with renal involvement. And the poor things is almost 8.1 die due to lupus disease. So it's not so good lupus study, but we would like to have our patient in the good condition. So we try hard, improve our management in our lupus patients so they can have good outcome. This is the data that show that almost the same with other young age, and then they have to follow up quite a long period. And when we include our patient in the lupus APLC database, then we can see here that along the disease in Asia Pacific country, we have almost 60%. So 6 out of 10 patients of lupus involve their renal. So means that it's more severe compared to Europe or USA. And like Professor Eric mentioned, that the organ damage is almost 40% has at least one organ damage of our lupus in Asia Pacific country. So the next, we tried to publish our study. Then here I can show you This is a very simple study. Compare the pediatric onset of the lupus patient compared with adult one. Get published in the Lupus just 2022. Then I can show you the arthritis and hematologic involvement is more in childhood onset compared with the adult onset. So with this, we involve many specialty to come to us with more studies, and I can show you study more and more. This is several study that published about the anemia, as well as this one is also good, just published in Lupus 2021, about the cutoff. Sometimes very difficult, like your country, also in my country, to always check for anti-DSDN and complement. We can use the neutrophil to lymphocyte ratio. Then we put up the cutoff 2.94 to show you that this, with the not really good sensitivity, but good specificity, to show this is the active disease of the lupus, but we exclude the infection. And this is study for pregnancy. We also show what is the risk factors for poor pregnancy outcomes. And our cardiology come also with the carotid arteriosclerosis to see the plaque. And then with the psychiatry, we have the other study about the association of psychosocial stressor in our lupus patient. And with the specialist from rehabilitation medication, medical rehabilitation, they did some exercise to our lupus patient and found out this outcome is good. Then the last, our colleague from the pharmacy, they did the genetic, pharmacogenetic. This is very important, as one of you asked a while ago, why someone is respond well with the MMF, the other one respond well with azathioprine. Maybe there is a genetic factor involved into that. So now we did several genetic study, like we would like to see who the one who respond well with the cyclophosphamide, and the other one is not, why. Maybe there is involved of some genetic. So more on genetic study start to be done in our lupus cohort. And with other member, we also do several other study. So I would like to show you this, our just published the comorbidity with the tuberculosis. During the COVID in year 2019-2020, and we did several literature study to set up the Asia Pacific consensus statement on management of SLA together with Professor Navarro and also Professor Sisimok, you can see here. Then this is just published in Lancet 2021, and in this consensus, because lack of study, we put up the statement, the active tuberculosis should be excluded before immunosuppressant. So we all know about that. However, screening on treatment of the latent tuberculosis is not routinely recommended. Yes, because this is lack of the study. So the next year we did another study to look for what is the prevention of infective complication. This is just a collaboration study in systematic literature review. Then we found out that actually the high disease activity as well as the high dose of steroid, it's increased the risk of getting tuberculosis in our SLE patient. But there is no recommendation yet to given the prophylaxis for our lupus patients. So that's why with this we did another study, collaborate with our expert from the Netherlands. They have expert in tuberculosis, and the other one is Professor Philip from Otago. He's good in epidemiology, and with other members. We did this one, is tuberculosis among our lupus patients. It's a cohort, retrospective cohort study. So with all our data, around 1,278 patients, We follow them up for median follow-up 2.3 years with total follow-up 4,808 person year. And what we found is 131. So almost it's around 10% of our lupus patients develop tuberculosis after they're diagnosed as SLE. So it means 1 out of 10. I don't know what is the number in Philippines now, but it's a quite high number. The incidence rate is 48.5 per 1,000 person years in the first years, means that 10 times higher than the background population. So for this, we also noted that extrapulmonary tuberculosis is higher. It's around 8% with meningitis and 11% with military TB, and 10% out of them died during the diagnosis of TB. And also we see that estimated cumulative TB here, as I told you, in the first year around 10 times higher with the compared with the background. So this study also showed the risk factor for developing tuberculosis in our SLE patient is the age diagnosed less than 25 years, if they have no BCG vaccine, or if their family with tuberculosis, they develop 7 times to develop tuberculosis among our lupus patient, as well as if they have received high dose of the steroid. So means that we must be careful if our patient can develop tuberculosis. So tuberculosis is still one of the interesting things to be studied. So we did more and more study on tuberculosis with SLE. So the next chapter, I would like to show you some achievement from our center. We involved into the several presentation in the Congress of SLE. Even our student can do some local oral presentation from this study, and also we also involved into several meetings, even in Uplar. I have several presentation due to with this study. So for the end of my presentation, I would like to show you that the long road for the lupus research study, now we have almost 80 paper published, and then it's also very like a good achievement from our center, because start very simple one, but now it's bigger because we have the good collaboration with other members. Then we try to achieve the better quality of life of our patient. So with that, we also did more education to our patient. We know what is the problem, like from the study, we know the problem for the pregnancy, we know problem with the infection. So that's why we have more focus how to educate them. And also we are involved into the Uplar breathing. So with the summary, so it's very important to set up good backbone for the SLE research in your site. If you want to do study, then it's very important to set up the good backbone. Then collaboration is crucial. It's very important. Sometimes you need the fund. It's very important to get the fund. So in our country, if a student want to do some study, they can make a good proposal, and then we can ask for from the university funding. So that's good things that we can do more study. And you have to focus and dedicate best effort for this study. And another important thing that get yourself published. Otherwise, it's not been known by other. So for the rest, I would like to invite you to Lupus Congress in Korea this coming May. Then for the World Lupus Day, we have decided the topic for the theme for the World Lupus Day this year is the hope for the butterfly. Hope to see you there in Lupus. So with that, I would like to I quote this Mother Teresa quote that not all of us can do great things, but we can do small things with the great love. Thank you very much for your kind attention.
Thank you so much, Lani. Another round of applause for Lani. You know, very, very prolific And we are so proud of her. All of us Filipino rheumatologists are so proud of her because she has actually become one of us. And we have the same mindset. And I hope that presentation has truly inspired you, especially our young people. Especially our young people, just get yourself published, just write it up, all those case reports. And again, it's so fitting that this session came after the researches that we heard this morning. So it is truly, truly heartwarming that we have many young people who are now interested in getting yourselves published. And we hope to see more and more of that in the future, especially from us. And truly, truly, Lani, Dr. Hamijoya has given us a very good example of how she has come from a young fellow in training. Even during training, she has already published or come up with a lot of papers on this, especially on lupus. So again, thank you so much. We will have more of these questions coming up, and I hope you're seeing the QR code. You're seeing the QR code on the screen. That's for your Slido. So Slido, post your questions, and I think we're getting the questions coming up now. So can we have, and you can just place it anonymous. If you're scared to put your name there, just place it as anonymous. Ask your questions. So we can have this is a very, very interactive session on SLE. So even questions on the presentation of Professor Eric Morand on the lupus low disease activity, we have people to answer that question for you. We have Michael T., who is part of the APLC. We have, of course, the next speaker, we have Dr. Leonid Zamora, to also give you more answers or clarifications on the APLC. And we have, of course, Dr. Laniati Hamijoyo. So you can have questions on the LLDAS as a treat to target. You can have questions on the APLC in form of lupus collaboration research. So indeed, not all of us can do great things. To quote again Mother Teresa, not all of us can do great things, but we can do small things with great love. Thank you for that final quote, Dr. Hamijoya. So let's now move on to our next speaker. Again, it's a hot topic. Professor Moranda started off with steroids. Keep those steroids low in our patients because that is one of the greatest factor for damage in our patients with lupus. So let's hear it, especially with lupus nephritis, and Dr. Hamijoyo has emphasized the fact that in our part of the world, lupus nephritis is one of the, is actually the highest mortality, highest reasons for mortality and morbidity among our lupus patients. 60% have some form of nephritis in our part of the world. So that's, and indeed, it's also another hot topic on this. And to give you more specifically and focus on steroid-sparing strategies in lupus nephritis, we have also another young, budding, prolific fellow here. We have Dr. Leonid Zamora.
Good morning. Thank you to PRA for the invitation, and of course to Professor Navarro for always involving me in these kinds of CME activities. So I was tasked today to give you a presentation on the steroid-sparing strategies for lupus nephritis. So I have no disclosures for this presentation, and let me just give you a brief history on our love-hate relationship with corticosteroids. Since we are in a Reconnect PRA convention, let's reconnect again with corticosteroids. So the history actually started in around 1950s, because before the advent of corticosteroids, the 5-year survival rate for lupus nephritis is just around 17%. And in 1950s, when we introduced corticosteroids for the treatment of lupus nephritis, it actually improved the 5-year survival of lupus nephritis patients to around 55%. But the price to pay that they have to accept was that there are a lot of side effects with the corticosteroid use, albeit high corticosteroids were given to these patients with lupus nephritis. So in 1969, there was a glucocorticoid combination with your immunosuppressants, particularly the oral cyclophosphamide and your azathioprine. And with the use of this glucocorticoid combination with your immunosuppressants, it improved, greatly improved the 5-year survival rates of lupus nephritis to around 80%. And it also showed that by the use of the glucocorticoid immunosuppressant combination, it prevented a lot of the patients with lupus nephritis to progress to ESRD. But in 1986, the NIH had this publication that they were using now the IV pulse cyclophosphamide in combination with low-dose glucocorticoids. And this has been a standard since 1980s to 90s to 20s to about the year when I started fellowship. And it hasn't changed a lot since the time when we were doing fellowship around 2013. So in 2004, Contreras and his group used this IV cyclophosphamide. Here, it's a short duration of IV cyclophosphamide for 7 doses for monthly. And it was followed by MMF versus the azathioprine, of course, in the background of your glucocorticoids. The renal survival for patients who received IV cyclophosphamide and then later on was shifted to MMF was around 95%, and versus azathioprine, which is 80%. But again, there were a lot of questions on the methodology because all of these patients received a background of IV cyclophosphamide for 7 months. I mean, 7 doses of IV cyclophosphamide. And this is where love-hate relationship with glucocorticoids started. The doctors then saw the adverse events of corticosteroids, and so they were looking at different treatments to lessen the dosing of your glucocorticoids. And for the past 30 years, cyclophosphamide has been our standard. And some experts would say that it's a double-edged sword. We want the efficacy of your corticosteroid because it decreases the inflammation, it decreases the lymphocyte activity and proliferation, which is central to the pathogenesis of SLE. But we hate, of course, the dose-dependent adverse events and the time-dependent adverse events of our glucocorticoids. And so these are just enumerated adverse events that we can see in terms of the dosing and even in the time-dependent AEs for our glucocorticoids. If we give methylprednisolone pulses to our patients, of course, we always monitor them for acute cardiovascular and cerebrovascular events during and immediately after methylprednisolone pulses. They could have hyperglycemia and uncontrolled hypertension during and immediately after methylprednisolone pulses. So when we do give high-dose glucocorticoids, other than the cardiovascular and cerebrovascular events, of course, they do develop metabolic conditions. And now you have insulin resistance here. You develop myopathies in this patient, peptic ulcer diseases, mood, psychiatric and sleep disorders, and even a vascular necrosis. And the longer time you put your patients on glucocorticoids, you now see end organ damages. You have dyslipidemia, glaucoma, osteoporosis developing among these patients. And in the Hopkins lupus cohort, they saw that by just cumulative average dose prednisone, you can see here that more than 6 milligrams of prednisone per day increases 50% of your risk to develop end organ damage. More so if you have more than 18 milligrams per day of prednisone, it increases your risk of developing organ damage to 2.5-fold. And so we are now here to present to you the different strategies that we can do to minimize our glucocorticoids in our lupus nephritis patients. So first is the strategy to minimize the glucocorticoid exposure during the induction phase. So you have different objectives, of course, when we give our glucocorticoid decreasing or minimizing our glucocorticoid exposure. First, if we want to reduce the peak glucocorticoid dose. Second is reduce the duration of exposure to high-dose glucocorticoid via faster glucocorticoid tapering and limiting the cumulative dose from prolonged administration. So what we can do is to use IV methylprednisolone pulses to limit the glucocorticoid exposure of our patient, because the administration of your IV methylprednisolone pulses may allow you to use lower initial oral glucocorticoid doses. And these are just some of these studies where we based, where this, statement was taken from, because there were nephritis trials from the previous years, particularly the Lupus nephritis trials, where they used IV methylprednisolone pulses of 750 milligram for 3 days, and then tapered it quickly to just 0.5 milligrams per kilogram per day. Whereas in the previous regimen of the NIH protocol, you actually use 1 milligram per kilogram of prednisone. And then it was tapered to 10 milligrams per day by 6 months. In the MyLupus trial, however, they compared 2 groups here. So this set of patients received methylprednisolone of 500 milligrams for 3 days on the background, of course, of your MMF. And then you have 2 groups here, the high dose group and the low dose or reduced dose group. The high dose was 1 MKD, the reduced dose is 0.5 MKD. And it showed that there was really not much of a difference in terms of the complete renal responses at 6 months among these patients who received high dose glucocorticoids, around 19% of complete renal response, and reduced dose of glucocorticoids at around 21%. But more recently, we have the Aurora LV and the Aurora trial, which use the lowest peak oral glucocorticoid doses and faster tapering. So in the regimen that they used in this clinical trials, they used IV methylprednisolone of 250 to 500 milligram pulses with just 2 doses of those pulses, and then rapidly taper it. The starting dose after the IV methylprednisolone was around 20 to 25 milligrams per day. And then they were able to taper it effectively to 5 milligrams by week 12. And so if you can see the graph earlier, the target was 6 months from the previous trials to taper your prednisone to lower than the physiologic dose, which is 7.5. But here, in the voclosporin trial, they actually were able to taper the corticosteroid to around 12 weeks after institution of your IV methylprednisolone pulses, and of course, administration of your voclosporin. So the complete renal response at 12 months in these patients, MTT is of course the voclosporin plus the background of glucocorticoids and MMF. It showed a complete renal response of around 49% versus the standard of care, which was MMF with glucocorticoids at 24%. And this has now, okay, let's just review it. We do have the dose-dependent and you have your time-dependent adverse effects. The 3 green bars there would be your methylprednisolone pulses. So when we institute that, in this voclosporin trial, they were able to put the prednisone doses below 30 milligrams and then taper it to lower than the physiologic dose by 12 milligrams. And this has led, actually this data led the KDIGO to include a practice point in terms of the reduced dose scheme, mimicking that of the voclosporin trial. So they pointed that a regimen of reduced dose glucocorticoids following a short course of methylprednisolone pulses may be considered during the initial treatment of active lupus nephritis when both the kidney and the extrarenal disease manifestations show satisfactory improvement. However, this is very low certainty of evidence. No? There were lots of bias, and because there were no head-to-head comparison between the standard dose scheme, moderate dose scheme, or the reduced dose scheme in terms of the outcomes of renal outcomes and mortality, all-cause mortality. So here in the reduced dose scheme, you can see by week 9, 10, and week 11 to 12, you're more or less in the physiologic dose and below the physiologic dose of glucocorticoids. And that's what we want. To put the patient on the lowest glucocorticoid dose so that we can avoid the adverse events of our corticosteroids. How about the medium dose glucocorticoids in combination now with your new immunosuppressants and biologics? So the Nobility trial, which is obinutuzumab in combination with your MMF, used the lower doses or medium doses of glucocorticoids with just 0.5 milligrams, sorry, that's 0.5 milligrams per kilogram per day, no? With fast taper to 7.5 milligrams by week 12. The investigators there were given the option to administer IV MPPT depending on the disease severity of the patient. Comparing the complete renal responses at 52 weeks, we can see that 35% had complete renal response with the Nobility trial, and these patients were able to maintain their responses at 2 years, at 104 weeks, with 41% of them getting complete renal response with the obinutuzumab and MMF combination. Next question. Doc, can we have a regimen free of oral glucocorticoids? So, well, I guess yes, because the rituximab trial, which is of course your rituximab, 1 gram, and then given for 2 doses, and then you have your IV MPPT plus MMF, and then these patients were not given any oral glucocorticoids in the design of this trial. And you can see that the complete renal responses of these patients at 52 weeks was around 52%, and the total response, which would include your partial response, and of course your complete response, would be around 86%. The patients that were included were class 3, 4, and 5 lupus nephritis. However, there's a big however, when they stopped the rituximab in this trial, in around 20 weeks, these patients had nephrotic range flare, or nephrotic range proteinuria flare. So how long can you give a rituximab, especially in our setting? That's a big question. But this trial actually supports the concept that we can use a biologic, no, and facilitate a glucocorticoid-free regimen for our lupus nephritis patients. So this was actually the systematic review done by Shireen Un, no? Which is a colleague by Professor Eric Morand as well in Monash. And they saw that biologic therapy the use of your biologic therapy can lead to steroid-sparing effect. And they've enumerated here a lot of the different clinical trials using the biologics. And they saw that belimumab here, and other drugs such as tabalumab had a steroid-sparing effect. But she said that steroid sparing can be achieved in patients with biologic, who have received biologic, but needs to be implemented as a target at the very initial stages of treating our lupus nephritis patients. So we need to have a clear goal in our patient that we need to put them in the lowest lowest dose of steroid possible, no? And most of the time, our goal is 6 months. But what we can see in the other trials, particularly in the voclosporin trial, is that we can do that in 12 weeks or in half of that 6 months time, no? So this is just showing, this is part of the study by Shireen Un, that you have lower doses of your corticosteroids when these patients were given belimumab. So strategies to minimize glucocorticoid now during maintenance. So we've discussed the data or the clinical trials that use different designs on how they use glucocorticoids in their studies. Now, how about maintenance period? So we should maximize our use of antimalarials in all of our lupus nephritis, if not all lupus patients, because they lower the incidence of our disease flares and may reduce the long-term organ damage from the disease activity. So how about the use of biologics for maintenance therapy? So far, there's really scarce data in terms of maintenance, but the Italian group, they kind of adopted the 4+2 regimen of rituximab, which they use in ANCA-related vasculitis. So what they do here is they give rituximab at 375 grams per meter squared every week, and then another dose at 1 month and another dose at 2 months. No? And in this strategy by the Italian group, this is an observational cohort, 4-year observational cohort by, what's his name? Rocatero, or something like that. And so their cohort showed that no flares were seen during the follow-up without need of prednisone dose beyond 5 milligrams per day. The BLISS LN, or the belimumab lupus nephritis trial also, on the background of MMF or cyclophosphamide, showed better response and stable GFR beyond the induction phase, because this is a 2-year trial, and they've shown that these patients were better compared to the control group when they received belimumab. And so with the data on the rituximab and belimumab, there's a new clinical trial now ongoing. It's SynBios. It's a combination of your rituximab, and then patients will go on into the maintenance with belimumab to reduce the general immunosuppression of these patients. So these patients will receive MMF prednisone with methylprednisolone pulses, and then they will be given rituximab and belimumab, and they'll be observed for 2 years. This study will be completed at around 2025. No? Okay, so this is more or less on the end part of our presentation. So when we consider glucocorticoid dosing strategies, we have to consider whether we are giving the dose too low or we're tapering too rapid. Because when we do that, we put our patients probably at risk to having more lupus nephritis flares. And of course, you'd be increasing your corticosteroids there or increasing your immunosuppressants to control those flares again, which can worsen the kidney damage over time. Or when we do give doses too high or the treatment too long, we now get or cause glucocorticoid-related organ damages. So again, the target here is to give the glucocorticoid or give different glucocorticoid strategies to keep the cumulative glucocorticoid doses low, while of course minimizing the risks of flares and of course the adverse events of your glucocorticoids. So a word of caution, when you saw the different steroid-sparing regimens there, one size does not fit all patients. When we discuss SLE patients, it's always a highly individualized therapy that we give, depending on their phenotypes, depending on their extrarenal manifestations, depending on what they can afford in our setting. So future steps, as a clinician, as a society, and as an association, of course, is if we could always aim at using the lowest effective dose of glucocorticoids or use of glucocorticoid-free regimens, if possible. Study the safety of efficacy of CNIs, particularly of the voclosporin. It's a new calcineurin inhibitor, in combination, of course, with our standards, MMF, for example, to decrease the exposure of our patients to the adverse effects of glucocorticoids. And of course, as an association, it's our responsibility now to make these immunosuppressants and biologics accessible and available to our lupus nephritis patients. So that's the end of the presentation, and I'd be open to your questions.
Reminder, so post your questions on Slido, comments, questions on Slido. Do we have questions at this point? Thank you so much, Leonid, and I'd just like to flash back the last slide. I think I lost that last slide. Going to future steps. This was trying steroid sparing strategies. We need to spare our patients from too long high-dose steroids. So we need to give them the lowest effective dose of glucocorticoids or use glucocorticoid-free regimens. In our setting, that is easier said than done. Study the safety and efficacy of CNIs in combination with standard of care. So on the CNIs, it's an oral drug, part of the oral drug that we can give our patients. And very, very important, I thought maybe we should make this bold. Make the immunosuppressants and biologics accessible and available to our lupus nephritis patients. Dr. Noel Perez and the board of Philippine Rheumatology Association, you have indeed taken important steps already in providing DMARDs, biologic DMARDs, making them more accessible, and thank you for that. For our patients with rheumatoid arthritis and psoriatic arthritis or ankylosing spondylitis, we would like to request and maybe even pose this as a challenge to Philippine Rheumatology Association to make the cost for at least the biologic belimumab to be available for our lupus patients. And you saw how this is important for our patients. So thank you again. Thank you very much for that. Thank you very much, Dr. Laniati Hamijoyo and Leonid Zamora. So Lani and Leonid, thank you for your presentations. And we have a lot of questions that have come in on Slido. So here's a question from Mel Villamin. How long and at what dose should MMF be maintained to sustain low disease activity among patients with non-renal lupus? I think that was answered. Sorry. Okay, Dr. Lani, what were the unforgettable challenges you faced when you were starting your registry? Down to what were the challenges, especially when you were just starting your registry?
Thank you for the question. Yeah, it's a lot of challenging actually. I met during make the registry. The first is not complete data. You know that it's very difficult to get all complete data that you like to include into the registry. That's a big problem. The second one, somebody who really care to complete the data put into the registry is also very challenging for us. So at the time, we ask the students who wants to join and then involve into the registry, they can use the data if they involve. So that's one of the challenging things that we encounter during make the registry. Thank you.
So the message is really to involve as many people as you can.
Yes, po.
Starting off with friends.
Yes, po.
Starting off with students that you can tell them, okay, you have to do this, otherwise.
Yes, po.
Yeah, we have to be practical, especially in our setting, and encourage. I think this next question now is for Dr. Zamora. So, from Dr. Millicent Ong. Rituximab is much more expensive than steroids. Will this be cost effective?
Of course, when we formulate our therapies for our lupus patients, we always consider what they can afford. And so we have to individualize again our treatment. If we put the patient to becoming poor, then it's not a recommended approach to treating this patient because they will die of hunger afterwards, diba? So we have to make the decision sometimes for our patients, weighing, of course, the risks and benefit, and of course, taking into account the cost effectiveness and economics involved in prescribing medications.
Is it any different between lupus nephritis and extrarenal lupus?
In terms of the decision
In terms of
formulating.
dropping down or using these steroid regimens, steroid sparing regimens, comparing lupus nephritis and extrarenal lupus.
Okay. So when we see SLE patients, of course, we tend to give higher doses of glucocorticoids when there's major organ involvement. And so definitely you have to take into consideration what is the organ involvement of your patient. For example, if you have extrarenal lupus that only involves the cutaneous or the joints of this patient, they won't benefit as much as of giving high dose glucocorticoids as much as those who have major organ involvement, such as CNS involvement or kidneys, for example. So again, it's highly individualized, knowing what kind of manifestations your patients have before formulating your treatment regimens for these patients.
So the bottom line is still to really, really prevent the damage you have from steroids. And steroids are number one in producing damage, whether it's lupus nephritis or whether it is extrarenal lupus. So, well, we need to really, really cut down on our steroids as early as we can. But there was a word of caution, of course, with your, especially in lupus nephritis. Just make sure you don't cut it down too low in patients during the induction phase. And it is during the maintenance wherein you can now have a much, much better leeway in reducing your steroids in patients with lupus nephritis. So, any more questions? There was one question here. There was one question on how long. Okay. Now this is on lupus nephritis. In patients who already have gone into the damage of end-stage renal disease with ongoing hemodialysis, when can you offer renal transplant? Anyone actually in the audience can answer that, and nobody will have there's no incorrect answer here. So the question
when is the best time?
When is the best time to offer patients renal transplantation?
Well, if I remember, my co-fellow back then had a study on doing preventive kidney transplantation. So we don't wait for patients to develop ESRD or be on dialysis before we plan to have kidney transplantation. It should always be part of your conversation with your patient that they may need kidney transplantation, as we know that this kinds of organ involvement is long-term, if not lifelong.
Dr. Hamijoyo, how is it in your own, in Bandung?
Yes, I think same po. But it's very difficult in Indonesia to find somebody who wants to transplant or get kidney transplant until now. So yeah, it's very difficult.
Show of hands. Show of hands. Anyone who, in lupus patients, anyone would go for lupus patient with quiescent disease, you should have no more lupus activity before you offer transplantation. We all know that. So that's basic. But I want a show of hands. What about preemptive? In other words, preemptive, you have a patient who has lupus nephritis, lupus, quiescent, negative antibodies, normal complement, no more activity. And this is a candidate for kidney transplant. You're all listening. Since you're not typing in your questions on Slido. So now I will ask you a question. So that's the scenario in this patient. How many of you would you advocate preemptive? Is Dr. Len here? Doctor, how many of you would advocate? So Len, I want you to comment on this also. So, how many of you would advocate preemptive transplantation even before this patient would have to undergo hemodialysis? So quiescent disease. Just raise it up higher. So I want to. Thank you for being brave enough. Yes, actually, I would also personally, I would consider that. Because once you put in the long-term hemodialysis, start them on that, that is a patient who will have, am I correct, Dr. Len? Luga Lizardo.
Good morning, Dr. Leo and Dr. Amij. I was in training during my rheumatology fellowship. I did a study on preemptive kidney transplant among patients with lupus nephritis. And the study showed that the result is better. It has good results, no, in terms of lupus activity and improvement in the kidney function. Because as we know, the longer the duration of a patient on dialysis would really has an effect on the function of the kidney itself. So I think in that particular study, there were a few patients that I did get. No? Of course, I asked my friends from other institutions who also did preemptive kidney transplant, and some of them would do it, but others would not. So it's still not really traditional practice to do it. But in what I know, and in that particular study, and in some of the readings that I did before, it did have good results.
Yes, and it's a new concept. It's a relatively new concept, aside from just doing long-term hemodialysis on these patients. Of course, there's a lot of expense. So let me ask the question again. So would you consider preemptive kidney transplantation before setting them up for long-term hemodialysis? After Dr. Lizardo, how many of you? I now have 2 or 3 additional hands up. So again, great. So you would consider that, because we think that the most important for any patient, quality of life is so important. So that's the main thing. So we as rheumatologists, they consider that as us. As a specialty, we are very, very much patient-centered, so we need to consider those factors as well. So we've had a full morning, at least for the first part here. Thank you to Dr. Professor Eric Moran. Thank you, Dr. Hamijoya and Dr. Leonid Zamora. We'll let you rest for now. So we will have a 15-minute break. Go visit the exhibits before we move on to the case discussion. Thank you. And again, please post your questions on Slido. Keep that active. Let's be more interactive.
Thank you very much, doctors, speakers, for a comprehensive approach to lupus. Let me now call on Dr. Rosario Baez and Dr. Michael Gomez, our overall chair and chair of scientific community, respectively. And please award the certificate and tokens of appreciation. Thank you so much to our chair, Dr. Joseph Patricio, chief moderator, Dr. Sandra Navarra, Dr. Leonid Zamora, and Dr. Lianti Hamijoyo, and of course, joining us virtually, all the way in Australia, Dr. Eric Moran. Thank you very much. So ladies and gentlemen, please settle in now. Find your place in this room. Make yourself comfortable. We are about to start right now. Ladies and gentlemen, our next chair to moderate is a graduate of UST Faculty of Medicine and Surgery, graduate of fellowship training in Rheuma from UST, Medical Specialist 3, East Avenue Medical Center, Section of Rheumatology. Ladies and gentlemen, let's all welcome Dr. Annette Rasso.
Good morning, everyone. So now we will proceed to a case discussion. It's an interesting case about cardiomyopathy and pulmonary hypertension in a lupus patient. You have met part of our panel before. Joining Dr. Hamidjoyo and Dr. Leonid Zamora, we have our speaker from yesterday. She is a summa cum laude graduate of Doctor of Medicine and Surgery, University of Santo Tomas, Faculty of Medicine and Surgery. She had her residency in internal medicine at Danbury Hospital, a Yale University affiliate at Danbury, Connecticut. She had her fellowship in rheumatology at Rhode Island Hospital, Brown University Program, Providence in the USA. She is the section chief of rheumatology at VACCH. This is the Veterans Hospital in Fresno. And this is Dr. Candice Reyes. The other member of the panelists that I will be introducing is also a graduate of the Faculty of Medicine and Surgery at the University of Santo Tomas. He had his fellowship in rheumatology and clinical immunology at UST. He had his fellowship in adult and critical care medicine at the Asian Hospital and Medical Center. He is currently a part of the training committee of the Medical City in Pasig City. This is a fellow Thomasian, Dr. Ramon Miguel M. Molina. And presenting the case this morning is the Chief Fellow of the University of Santo Tomas Section of Rheumatology. This is Dr. Vincent Lucenio. So let's sit back and watch this.
Hello, we're back in business. Lupus is back in business as always. So again, a reminder, please post your questions on Slido, and you can remain anonymous. It's fine. You can post also comments, and you can put in your evaluation of this session on Slido. That's fine. So please feel free. We would most encourage that and urge that for an interactive session. So now we have the case challenge. Very interesting case. And here, I would expect you to put in your comments. If not, use the microphones for any questions that you may have or any comments you may have. So this is everybody's case. We have a patient who has lupus nephritis, who develops cardiomyopathy and severe pulmonary arterial hypertension. So thank you, Dr. Vincent Lucenio, for preparing the case, and of course with his friends, co-fellows, as case writers as well for this. Again, thank you, Dr. Laniati Hamidjoyo. Dr. Candice is back after their lectures, and Leonid Zamora. And we have fresh from critical care. And that's the reason why, even if he's a rheumatologist, he went into intensive critical care training. And certainly should be able to answer us on points of critical care, which is very, very relevant in this patient. So we have Dr. Ramon Miguel Molina. Okay, let's have Vince, can you start with the case?
Good day, everyone. I am Dr. Lucenio. I am a fellow from University of Santo Tomas Hospital. Presenting a case of a 39-year-old lady diagnosed with SLE in 2004. She initially presented with alopecia, malar rash, oral ulcers, photosensitivity, anemia, thrombocytopenia, proteinuria, low C3, positive for ANA and anti-dsDNA. She was initially started with cyclophosphamide and maintained on azathioprine, hydroxychloroquine, and glucocorticoids. In 2005 to 2019, she had infectious complications, which included brain abscess. An emergency borehole was done, and there showed species growth of Corynebacterium and actinomyces. She also had pulmonary tuberculosis and was treated for 6 months. Patient also had intermittent flares of nephritis and CNS, which responded to steroid pulses. In 2019 to 2021, patient had a quiescent disease. A year prior to the present illness, she followed up for management of her first pregnancy at 4 months gestational age. SLE had been clinically quiescent since her last clinic visit 2 years ago, despite poor compliance to medications and follow-up lab monitoring. The entire pregnancy course was uneventful, and she delivered term by normal spontaneous delivery to a healthy baby boy without complications. Post-operatively, she had the normal CBC, creatinine, urinalysis, and chest X-ray. During the postpartum period, patient was noted to be sedentary, and there was no breastfeeding done. She experienced occasional exertional dyspnea, and also she had a localized skin infection, which was resolved. However, 5 months later, during her clinic visit, the patient showed at the clinic actually she was ambulatory with normal vital signs. However, this time, she had occasional exertional dyspnea. Laboratory results showed polycythemia and 3+ proteinuria. The patient was advised for admission. However, she opted for an outpatient workup. A week after the clinic visit, patient came in at the emergency room due to chest pain and shortness of breath. Patient was tachycardic and tachypnic, but with normal blood pressure. Upon physical examination, she was noted to have distended neck veins, dynamic precordium, parasternal heave, and accentuated S2. She has basal lung crackles and a grade 1 bipedal edema. Her laboratory showed polycythemia of 182 grams per liter, 3+ proteinuria, and elevated UPCR at 4.79. However, the patient had a normal creatinine, troponin, and arterial blood gas. The ECG showed sinus tachycardia with right ventricular strain. This time, the chest X-ray of the patient showed cardiomegaly. A 2D echo was done, which showed concentric LV remodeling with wall motion abnormality. There was akinesia on the anterior and lateral mid to base area. There was also hypokinesia on the interventricular septum and inferior mid to base. Patient also had a dilated, elongated, and hypertrophied RV and depressed systolic function. Her ejection fraction was only 29, and the pulmonary arterial systolic pressure was elevated to 91 millimeters of mercury.
So just to summarize the case, this is a patient who was diagnosed lupus nephritis 2004, and fairly usual course of nephritis, or usual course of lupus. 2005, 2019, she had her infections, major infection in terms of brain abscess, and a common infection of pulmonary tuberculosis, both of which actually resolved. There were intermittent flares in this patient, as you would also expect in patients with lupus over the long term. Nephritis, including an episode of seizures that very well responded to steroid pulses. That was CNS flares likewise. And remarkably, this patient in 2019 for 2 years, right? So for 2 years, had quiescent lupus disease. And again, as expected for these patients, their follow-ups were relatively erratic at this time because they felt very well. She was also off steroids, or at least prednisone, maybe 5 milligrams, up to 5 milligrams, plus the hydroxychloroquine. Now, it was in December 2021, and as usual also, as we would expect from our patients, they would just come in because they're already pregnant without even a pre-pregnancy counseling or planning. And this turned out, thankfully, to be an uneventful pregnancy, delivered normal spontaneous delivery, live, healthy baby boy. Baseline, when I say baseline from the current event, baseline then, normal, note the normal chest x-ray, normal creatinine, normal urine, normal CBC. So that needs to be emphasized here because that was in December 2021. 5 months postpartum. So as would be expected again, because she felt okay, though she was kind of sedentary during this time, nothing to test her physical capacity. She didn't breastfeed. She was just sitting pretty at home. Her mom would do all the chores for her. So then she went for a clinic visit. So this is more of an incidental clinic visit. That's, I want to see my doctor. So that was 5 months postpartum. It was during this time that there was incidental note of a hemoglobin of 180 and 3+ proteinuria. Again, as we would expect, hematologic nephritis, these are the least symptomatic in our patients. But then if you probe further, I think the fellows probed further into this patient, there was already some exertional dyspnea. But it didn't bother the patient that much. So that was 5 months postpartum. Of course, she had to be worked up further. Now, while going for that workup, incidentally, she came with chest pain. And that brought her to emergency, wherein you had an emergency workup, which showed the cardiomegaly with akinesia, ejection fraction of 29%, and a whopping increase in pulmonary arterial pressure of 91 millimeters mercury. So, just focusing on this new onset, relatively new onset, because we just detected it now in our patient, on cardiomegaly, with the akinesia there, is this peripartum and or part of lupus in general, cardiomyopathy? First, because of its proximity to the delivery, can you give us an idea, Vince, on what would be postpartum cardiomyopathy?
Okay. When we speak of a peripartum cardiomyopathy, it is currently defined based on the presence of the 4 criteria. First is the development of symptomatic heart failure in the last month of pregnancy or within 5 months of delivery. Second is the absence of an unidentifiable cause of heart failure. Third is the absence of pre-existing heart disease prior to the last month of pregnancy. And the fourth one is the presence of left ventricular systolic dysfunction, wherein the LV ejection fraction is less than 45% and or fractional shortening of less than 30% on an echocardiogram. And take note that the incidence, the highest incidence, was seen in Nigeria and Haiti. 1 is to 100 to 300%. And in US, 1 in 1,000, 2 to 4,000. And in Japan, it's only 1 into 15,533. Peripartum cardiomyopathy actually is a diagnosis of exclusion. And this carry worse prognosis. Partial or complete recovery is common in peripartum cardiomyopathy, and nearly half of them, the recovery of LV function would happen in 6 months. So there are actually classical risk factors for patients with peripartum cardiomyopathy, and this includes your multiparity, multifetal pregnancy, the advanced maternal age, preeclampsia, and of course, gestational hypertension. So moving on, there are actually many cases of reported peripartum cardiomyopathy or myocarditis due to an autoimmune etiology. So although that we know that the cause of peripartum cardiomyopathy until now is unclear, it can be associated with myocarditis, autoimmunity against fetal antigens, fetal microchimerism, and dietary deficiencies of selenium or excessive salt intake. There have been case reports where acute myocarditis was the initial manifestation of SLE. However, this would often cause a diagnostic dilemma for the clinician. So take note that ECG and chest radiograph could be a largely unhelpful. However, the diagnosis would still depend on the clinical suspicion and the echocardiography findings. So we all know that lupus could cause inflammation in different parts of the heart and giving rise to endocarditis, myocarditis, and pericarditis. So peripartum cardiomyopathy actually is the most common cardiomyopathy in pregnancy, and this one is a form of your dilated cardiomyopathy.
Okay, so let's have the discussion now on that, focusing on the cardiomyopathy. Is it lupus or is it peripartum cardiomyopathy or is it both? Can we start with our intensivist?
Okay, thank you very much, Lucar. I think that is a very fantastic question. At this point or at the early outset of the symptoms, it's very difficult to really limit the diagnosis to peripartum cardiomyopathy or lupus cardiomyopathy because as we know, oftentimes they just present with heart failure symptoms and there's a very wide range of differential diagnosis in terms of cardiomyopathy, including viral. For example, COVID is something that we've encountered very recently. But I think it boils down to doing a very good history and a thorough physical examination and looking for signs of whether it's a left-sided or right-sided heart failure, and also supported with ancillaries and laboratory tests, we would more or less be able to delineate which type of cardiomyopathy is involved. But as I had mentioned, it's really difficult at this point because the patient actually fell into the time period or the time frame wherein peripartum cardiomyopathy may be considered. However, take note that peripartum cardiomyopathy is a diagnosis of exclusion, and therefore everything must be done, or we should do an exhaustive workup for the cause of the cardiomyopathy or the heart failure of this patient before we could strongly commit to a diagnosis of peripartum cardiomyopathy. Lupus, in fact, as Vincent had wonderfully presented, could actually be one of the main diagnoses po, Dr. because as we know, lupus presents or mimics a lot of cases po. However, the symptoms of the chest pain, the exertional dyspnea, which has been more or less chronic, would also point to a possible pulmonary embolism. The sudden chest pain could also signal either an acute event, a submassive one, or possibly a chronic thromboembolic pulmonary hypertension that caused right-sided heart failure. But it really depends on how we work up these patients in order to exclude the other diagnosis. So I came up with a table of comparison differentiating between peripartum cardiomyopathy, lupus cardiomyopathy, and CTEPH with core pulmonalia. Okay, and based from the history and physical examination, these are the things that we would more or less expect. And it was mentioned in the case presentation that this patient presented with exertional dyspnea, which is basically part of your heart failure symptoms, as well as decline in exercise tolerance. A tricuspid regurgitant murmur may, however, allow us to clinch the diagnosis and do further workup for that. Pedal edema may also be present in all types of heart failure. And other supporting evidence, like the biomarkers, may more or less narrow down our differential, especially if we're considering lupus cardiomyopathy. We expect some of our serologies to be positive or the complement to go down, which may signal a possible lupus activity at the moment. Aside from that, radiography would also be a good additional tool to help us out, but it's relatively non-specific. However, with the CTEPH, there are some specific or good chest radiograph findings, such as what we know as the Westermarck sign, the focal oligemia, and also the Pallias sign that we could see, yung sausage appearance of the right pulmonary artery. Okay, the ECG, the RV strain more commonly for CTEF and right-sided heart failure. If there are any cardiologists in the room, we really appreciate your inputs as well. But overall, it's non-specific. However, the main difference would now fall on the echographic findings, wherein in both lupus cardiomyopathy and peripartum cardiomyopathy, the typical findings would be global hypokinesia, okay, rather than segmental. But with CTEF and right-sided heart failure, the typical findings that we expect to see with our echocardiogram includes your segmental or global hypokinesia. You have right atrial and right ventricular dilatation and hypertrophy, and even the septal flattening because of the ventricular interdependence, because of the right-sided pressure overload. And of course, other things that can be measured with the transthoracic echo, like the mean pulmonary artery pressure, estimated. But the other hemodynamic parameters here cannot be determined via echo alone. And these needs either a right heart catheterization or maybe a Swan-Ganz monitoring to get the wedge pressure and the pulmonary vascular resistance. So I think that will be the clincher. And I don't know if we will be showing the echo clips for the para. They're very wonderful and nice videos or
We
images
can
for them.
unhide it if you want.
Okay, the para. So we'll wait for that.
Yeah,
But
we can wait for that. If anyone is interested in just let us know on Slido if you would like to see more of these clips. But
Okay.
yeah, for now, because I do have a question on the echocardiographic findings. Vince, did you say this patient that you mentioned that this patient had hypokinesia, akinesia? Was it global or was it segmental or was it both? Because I'm seeing here that in postpartum or peripartum cardiomyopathy, you have more of global hypokinesia. And to differentiate that with CTEF, with cor pulmonale, I could see two words here, segmental or global hypokinesia. So what did these patients 2D echo show? You reviewed the 2D echo?
yes,
Okay.
Doctor, I reviewed the 2D echo. It's not that I'm a trained echocardiographer, but because I'm not a cardiologist. So I would say in terms of training in echocardiogram, I'm at the very bottom. It's what they call the emergency point of care ultrasound that we do in the ICU. And normally, if we're dealing with peripartum cardiomyopathy or lupus cardiomyopathy, they often mimic the presentation of your dilated cardiomyopathy, wherein they present with global hypokinesia, valvular regurgitations. But with chronic thromboembolic pulmonary hypertension, because of the obstruction in the pulmonary artery, what happens is some of the changes that you see in the heart. First is the increase in the RA and RV load, and therefore the pressures increases, leading now to dilatation of your RA and your RV. Okay, so do you want me to discuss this, Doctor? Okay, so this one is the parasternal long axis view. It's not working. Okay, so just to orient everyone, this is the right ventricle, this is the aortic root, this is the LV outflow tract, and this is the left atrium. And normally, they should be more or less equal sizes. So you divide it into equal thirds. Okay, so what you could see here is that the RV is relatively larger than your aorta and your left atrium. Okay, and looking at it, I would more or less say that it's global hypokinesia, more or less just by visual estimate. Again, I'm not level 1, 2, or 3 echocardiographer, so this is just point of care ultrasound that I'm relying on. Okay, and now this one is interesting, Doctora. This one is taken in short axis view at the level of the great vessels. And just to orient everyone again, this is the right atrium, you have the tricuspid valve. This is the RV leading to the RV outflow tract. You can see here that moving object there is your pulmonary valve. And here, this is the main pulmonary artery. You see the bifurcation to going to the right pulmonary artery and to the left pulmonary artery. Now, and this is the aortic valve. Okay, and what we could see here is that again the RA is really dilated. The RV likewise, sorry, is likewise dilated. Sorry, there. And you also you could also notice that relative to the size of the aorta, you have a relatively dilated pulmonary artery, which is uncommon. And that may signify pressure buildup in the pulmonary arteries. That's why it dilates. Now, if you talk to any echocardiographer, oftentimes they will not commit to intimal irregularities based on echo alone, simply because these things that you see here may actually be just artifacts. But since I already have this anchoring bias, and I was thinking that maybe these are actually the chronic thromboembolic the thrombus that had set in, and you now have narrowing here with post-stenotic dilatation. So it really points more towards a pulmonary artery
Yeah,
hypertension from CTF, I think. Dr.
Okay, okay. So you could see here that even if we're now having a patient who has postpartum, 5 months postpartum, we're seeing all these changes, and you have a consideration that this is more likely thromboembolic than
It's a
really just
possibility.
frank. There were features here that were a little bit less likely to be postpartum cardiomyopathy.
Yes, Doctora. I think at this point, just by the echo, it's hard to really exclude those differentials that you've mentioned earlier, because we would need further testing, like perhaps a right heart catheterization, a VQ scan, and possibly a CT pulmonary angiogram in order to find whether there are really filling defects and intimal irregularities. Otherwise, as it is, they're all good differentials. This one is the D sign. This is the septal flattening seen on short axis view. You can see the interventricular septum. This is the right atrium. This is the this is the right ventricle, the left ventricle at the level of the mitral valve. And because the pressure overload here, it pushes the septum towards causing it to flatten towards the left ventricle. And this just shows the severe tricuspid regurgitation.
Hi, is this a cardiology conference? So let's
Not really, Doctor,
thank
but
you
I
so
think
much. You know,
the
there's a
echo is
lot of
clincher.
learnings here. And remember, we are faced with a lupus patient. So this is a lupus patient who gave birth, uneventful pregnancy, uneventful delivery. There was no chance to test her for exertional dyspnea or any other, which was the reason why I think the service who saw this patient first thought of, is this postpartum cardiomyopathy? But then the questions are coming in. And before we focus on that, we focus now on, is this cardiomyopathy, postpartum cardiomyopathy, or is this a chronic thromboembolism that we're seeing primarily in this patient based on that history? Okay. And I would just like, before I ask the other panelists who are here as rheumatologists and internists, so we have Dr. Zamora, we have Dr. Reyes, and Dr. Hamijoyo. So on a background, there are two questions here, and two questions, I will read the two questions together, one after the other. because it has some relevance to us as rheumatologists and internists, a lot of relevance. So first question is on the background of a rheumatologic disorder. Here, this is lupus. Should this patient undergo cardiac biopsy? That question is for you, Migs. To rule out other possible causes of pulmonary hypertension and heart failure, like mixed connective tissue disease. The other one is, before peripartum or lupus, or even lupus cardiomyopathy is considered, should you entertain also a coronary artery disease? And given that the patient presented with RV strain, suggesting right-sided heart failure, wherein the most common cause would be an LV failure, so we would look at the coronary as a culprit in a patient who may have accelerated atherosclerosis. Now, noting that SLE patients are also at high risk for cardiovascular events. So let me ask a basic question from our internist rheumatologist. What do you think would be the most common cardiac presentation in patients with lupus? And and what in your experience would come up with something similar to this, like cardiomyopathy in patients with lupus? Candice?
I would entertain coronary artery disease because in our lupus patients, accelerated atherosclerosis really should be considered. And especially if the echocardiographic findings are segmental, or it might have been a right coronary artery ischemia, and right heart failure might also mimic the presentation. Aside from that, also because lupus, its manifestations as well as the therapies we give, before committing to postpartum cardiomyopathy, which I definitely think shouldn't be excluded, there are other elements, at least not to forget. 2 decades at least of hydroxychloroquine use, although rare, hydroxychloroquine cardiomyopathy can be entertained, but not high on the differential. Another thing is in the social history, we wouldn't want this patient to be doing this, but in my experience in certain locales in California, amphetamines, the hyperadrenergic sympathetic state can also lead to cardiomyopathy and or heart strain. Coronary artery disease to be excluded, amphetamine use. What about antiphospholipid syndrome? Because there might have been a maybe even the lupus nephritis, thromboembolic phenomenon, and the hydroxychloroquine. So coronary disease, drugs to elicit use, or any other drug that may not be prescribed, herbal or supplements, and any atypical infections, myocarditis, because we do have immune suppressants, and so presentations of infections might not also be as typical. So things to entertain, but also might change the differentials because her presentation originally wasn't cardiac as her original presenting manifestations, and she doesn't have much of risk factors for postpartum cardiomyopathy, maybe just advanced maternal age. So certain other elements need to be considered, but first and foremost, accelerated atherosclerosis in a young lupus patient not to be excluded, and definitely, if possible, left heart cath, but confirmatory for pulmonary hypertension is also right heart cath that would capture left heart disease and coronary disease as well. But also, if really left with considering hydroxychloroquine cardiomyopathy, atypical infections, infiltrative diseases, or unclear diagnosis, then endomyocardial biopsy can be resorted to.
Dr. Hamid Joyo, in your experience, one of the things that bugs me in this patient, is this patient, if you look at the whole history of this patient, lupus 2004, so that gives you how many years of lupus? How many years? How many years? Join me in my mathematics, my poor mathematics. So 18 to 19. So about 18 years lupus. At this point, what would you consider in terms of cardiovascular involvement? Is it due to lupus? Because there's another question here. Is it due to lupus, or is it due to some other things? Are we now talking about damage also in this patient? including coronary, as
Yeah,
was mentioned.
That's what I'd like to ask Vincent about this patient. I really encountered that I also know this patient during my fellowship training. So for the very long period of lupus, high using a lot of steroid during her lupus, so it's also increased the risk for atherosclerosis. So I would like to ask Vincent, did you do the phospholipid test for this patient? And during her pregnancy, did she receive anticoagulant or antithrombotic agent like aspirin? Is it?
No, not on long term. Not on long term aspirin. If ever she was taking aspirin once in a while.
As clinicians, sometimes that the patient come with this manifestation. So first we refer to cardiologists, of course, but whenever we think this is lupus or not, so we have to look for other manifestations. Sometimes it's not come with only heart manifestation, but with other manifestation. We can look for other manifestation that she has, like she developed lupus nephritis at the time. Is it correct? At the time when she developed the heart disease, she also had previously when she pregnancy quiescence, and after that she developed also nephritis. Is it correct?
The nephritis,
During the time
we can
when
discuss on a later portion. I will ask you the same. I will remember to ask you the same question.
Yeah. So that's why if thinks that this one is belongs to manifestation of lupus, so we have to look for other manifestation as well as the marker for the activity of lupus. But
at this point, I can ask the four of you, when you have lupus nephritis, for example, would lupus nephritis in 18 years, would you expect it to flare? Never had dialysis.
maybe it's a little bit less so for quite a long period.
When
But
do you usually expect the flares in lupus nephritis? Is it the early part of SLE, or is it towards the later part of SLE?
can be
Active
happen,
lupus nephritis.
yeah, doctor, it can be happen along the way the disease, but most in the beginning, but it can be happen all the time, doctor.
Yeah. So she did have her nephritis flares in the period 2005 to 2019, that time. But at this point, wherein you now have 18 years all in all from diagnosis of lupus. Candice, you have the microphone there.
Sometimes that is the utility of having an initial renal biopsy, and then if there's quiescence, and then somewhat atypical, there's new manifestations and seemingly new flare, it might be a different process instead, like secondary development of FSGS or an infection, and then like FSGS, a change in pathology when there's periods of quiescence, and then a change in presentation now with heart and renal. So sometimes that's a reason why we rebiopsy and definitively know if it's an active inflammatory process or thrombotic microangiopathy, and potentially also clinch the diagnosis. So, but role of biopsy and rebiopsying is how we might consider dealing with a patient like this.
Okay, so something like this in a patient who does not have underlying lupus is fairly straightforward, right? But when you have something that happens, cardiomyopathy, whether it's global or segmental, in a patient with underlying lupus, you have a whole lot of differential diagnosis. I know you're raring to make a comment, Dr. Zamora. Just before I forget, Dr. Zamora, the question I was going to ask you, I think I first heard that from you. Takotsubo syndrome.
Hindi pa dapat kay Miguel. Takotsubo cardiomyopathy. Yes, go Miguel. Ballooning of the...
Just
Okay,
standing
Takotsubo.
here in front of Dr. Navarra, I have to monitor myself if I'm developing Takotsubo cardiomyopathy.
Ano yun?
But it's
Apical ballooning of the...
apical ballooning with hyperactivity of the basal septum. and because of that, you now have the configuration of the octopus jar, Japanese octopus jar. That's why it was named takotsubo. But that mainly results from severe emotional stress. So that's why the other terms for it is actually stress cardiomyopathy, Doctor. Now, before I lose my train of thought, first of all, excellent points from Dr. Candice and all the other panelists, po, Doctor. And I 1000% agree with what they said about working for other problems like ischemic heart disease. And that is precisely the reason I said that at this point, there's a very wide range of differential diagnosis that we have to consider and potentially work up and hopefully rule out before we come up with a single disease entity to really blame for the cardiomyopathy. And for the questions that were thrown in earlier, yes, endomyocardial biopsy is a good option in postpartum cardiomyopathy or lupus cardiomyopathy. However, from what I know in recent studies, it's somehow losing favor against the cardiac magnetic resonance imaging. Because number one, we try to, I mean, the experts, the cardiologists, they try to shy away from the more invasive procedures because, endomyocardial biopsy entails sampling some of the myocardial tissues. And yes, I agree. Coronary angiogram should also be considered in patients who present with segmental wall motion abnormalities, etc. Because again, the pulmonary hypertension and the right-sided heart failure is not, straightforward CTEPH. We must remember that still the most common cause of right-sided heart failure is left-sided heart failure. Okay, and therefore we have to exhaust all the diagnostics that we could do if the resources allow it before we come up with yung diagnosis of peripartum cardiomyopathy. That was my point po, Doctora. So, yeah, last one. And I'd like to cite yung study of Dr. Cabasan when she was a fellow and I was your student, research assistant, Doctora. This was done, I think, 2009 or 2010 with Dr. Reyes, cardio fellow at that time. They did yung pulse echo study, if you remember, Doctora. I helped them out with that. And if I recall, some of the common echo findings with lupus cardiomyopathy includes your pericardial effusion, valvular regurgitations, and sometimes yung global hypokinesia at that. And also the Liebman-Sachs endocarditis. It's one of the things that they found in the pool of echo that they reviewed among our lupus patients in UST, Doctor. So that's it.
Yeah, so there's a whole range. And reinforcing again that lupus is Pandora's box. So, and that is the one that makes you rheumatologists. Incidentally, yes, and we have a comment here. I'm not sure if there's a comment here in a lupus patient. So it looks like this is a comment from a rheumatologist who has close affinity with a cardiologist. Because in a patient with lupus, yes, is that correct, Vinny? Okay, so much more detailed. So cardiovascular workup should be considered. Yes, we certainly agree because of the history of previous medications. Much more detailed history in cardiac with right ventricular failure and very low, yes, detailed history and cardiac history in this patient is certainly warranted, which was done. So it's not what you see is what you get. You have to probe further. And global hypokinesia in the 2D echo. Maybe you can answer this, Mix, or address this. We would be interested in measurements. Would measurements give you an idea of what's causing the hypokinesia in these patients?
Which measurements, if I may?
By 2D echo, I would guess.
Maybe the chamber diameters.
Okay.
Maybe that's what Dr. Mina, is that correct? Maybe that's what Dr. was pertaining to.
That is what our rheumatologist who's affiliated
yes. And
the
she's actually
cardiologist is
my
asking
boss
now. And I'm sure
in the
they're
South.
discussing this also over a cup of coffee. As there's some reason that if you are, for those who are who has affinity or affiliated with another one from another specialty, and you're a rheumatologist, you just would like to discuss your patients with others and even challenge them. So, Danilin? Yes, I'm sure you're getting cardiovascular problems into your issues in your patients when you discuss lupus patients with your husband. Yes. Leonid, I have to hear from you.
Yes, Doc. Considering what the new information coming from from Mix, no, on the 2D echo of this patient, with the events happening postpartum, and then the occasional dyspnea of this patient, I think part of the consideration should be postpartum pulmonary embolism. And you've seen some evidences there that there might be a thrombus in the pulmonary thrombus there in the 2D echo.
Yeah, but
You can.
please don't quote me for saying that because I might get in trouble with the cardiologist. No, but as I said, that's just me having that anchoring bias.
Right. Okay.
So the luminal irregularities, you expect that with chronic thromboembolic pulmonary hypertension. But if it's like an idiopathic type of pulmonary hypertension, most of the time, from what I know, you do not expect to see that. You may see the dilated pulmonary artery trunk and the dilated RA and RB, but that's as far as we can go in terms of the echo.
To the echo, correct.
And that's why we have to go down further with in terms of the workup, like as I mentioned, VQ scan, CTPA, perhaps a right heart catheterization in order, because the right heart catheterization will give us information about the hemodynamics.
Right. Second point is this patient has elevated pulmonary arterial systolic pressures. So there's probably an evidence there that there's pulmonary hypertension in this patient. And then you also have erythrocytosis. So I would expect a patient with pulmonary hypertension, chronic hypoxemia, would also develop the erythrocytosis that we're seeing in this patient. And this might be a chronic process that's happening in this patient, and that we're just able to capture it 5 months postpartum.
Yeah, and related to that, there's actually a question on Slido. Would her underlying polycythemia, which is fairly recent, so normal 5 months ago, it was normal hemoglobin, now just rose up to 182 grams per liter. Would it have contributed to her cardiac problem and maybe the pulmonary arterial hypertension?
Yeah, wonderful questions, Dr. I agree it may contribute, but as you always tell us, former fellows of yours, Dr. We always have to do proper attribution. So we have to find out what really caused it. Is it the chronic hypoxemia that caused the erythrocytosis, or the patient has primary erythrocytosis from, I don't know, maybe from lupus or whatever condition that in effect caused a vicious cycle, putting this patient at risk for thromboembolism and then further hypoxemia. So it becomes a vicious cycle, and it's really a question of whether it's the chicken or the egg, I believe, Doctor.
Again, before we go off on our discussions and go overtime on this discussion, I'm sure we'll not hear the end of it. Let's just focus a bit more on the pulmonary arterial hypertension. Because you have been mentioning this, okay, well, maybe this is thromboembolic, more than just a peripartum run-of-the-mill peripartum cardiomyopathy. And let's focus a bit more on that pulmonary arterial hypertension.
An early and potentially reversible stage in the development of the disease. So all of these factors, although to a different extent, are present in most entities that result in the elevation of the pulmonary pressure, vascular remodeling is the most important and to date, the least treatable factor. So as such, remodeling is the factor that still defines pulmonary hypertension as a chronic and incurable disease. So we all know that the pathogenic mechanism of SLE with pulmonary arterial hypertension have not been elucidated yet. However, accumulating evidence suggests that multiple factors such as genetic predisposition, environmental stimuli, and immune system dysfunction plays a significant role. So the net result here is there is an imbalance between vasoconstrictive and vasodilating soluble mediators that would lead to vasoconstriction with increased pulmonary vascular resistance. So as we all know that endothelin, 81, and thromboxane are the main mediators that lead to the vasoconstriction. So their serum levels actually are significantly elevated in patients with SLE and pulmonary arterial hypertension, and this would correlate the PAH as severity. This one would lead to a pulmonary vasoconstriction that will lead to a decreased oxygen saturation and hyperexpression of your hypoxia-induced factor and erythropoietin, which will promote impaired smooth muscle, endothelial and interstitial cell proliferation, and apoptosis, and would later on have an extensive vascular or abnormal vascular remodeling. So in the parallel, the inflammation or the inflammatory markers or the accumulation of your neutrophils, monocytes, dendritic cells in the elastic lamina, this would induce the production of your chemokines and then your growth factors, which would also lead into abnormal vascular remodeling. So this one will lead into the increased pulmonary vascular resistance. Okay, so here is a very good risk assessment, that we need to remember in the PAH management. So we need to remember to get the biochemical markers of the patient, the clinical assessment, which would include the good function, the functional capacity, the progression of symptoms, signs of right heart failure, presence of syncope. And for exercise test, we need to do a CPET or the cardiopulmonary exercise test, and also a 6-minute walking distance test. And for the echocardiographic evaluation, we need to look into the right atrial area, and as well we need to look into the presence of a pericardial effusion. And also for the hemodynamic evaluation, we need to look into the cardiac index, the right atrium pressure, atrial pressure, and also the presence of a mixed venous saturation. So how do we manage patients, or what are the treatment options in pulmonary arterial hypertension? So these are the three targeted pathways in managing patients with pulmonary arterial hypertension. So the endothelin pathway, the nitric oxide pathway, and the prostacyclin pathway. And here are the list of medications given to patients with a PAH.
Can we have your take on this? Mix?
Yeah, I
How
absolutely
important are these parameters?
Well, all of these things are important, Dr. because as I have been repeatedly stating from the start of the discussion, it's important to correctly classify as to which type of disease we're dealing with. And if we all recall, the WHO classification actually gives us several categories of your pulmonary artery hypertension. And all of these things come into play because not all types of pulmonary hypertension would have the similar findings in all of these workup. And therefore, determining one from the other is very important because that would more or less guide us as to the appropriate treatment that we're going to give. For instance, in your idiopathic or type 1 pulmonary artery hypertension, the guidelines would say that it's okay to start simultaneous dual therapy with either sildenafil or bosentan or macitentan, or even sequential. But it doesn't necessarily apply for other types of pulmonary artery hypertension. And that's where the other types, such as those from a connective tissue disease, would come into the stage. Then we have to treat the underlying disease. Of course, we would still give some of those medications to lower the pulmonary artery pressures, but ultimately, You do not give, for example, immunosuppressants in idiopathic, but instead you give it for autoimmune connective tissue diseases. You do not give dual therapy with sildenafil and endothelin receptor and agonist in cases of CTEPH, but still the gold standard is pulmonary endarterectomy. Okay, in most operable cases, but in inoperable CTEPH, Posentan would be Posentan or Macitentan would suffice as a monotherapy. And going back to that algorithm, all of those things are actually important for us to correctly classify the type of pulmonary artery hypertension for the appropriate people.
Okay, so can we have comments on the pulmonary arterial hypertension?
I just want to like to add that as we know that pulmonary hypertension has a very bad prognosis, a poor prognosis for all, especially for the autoimmune disease, then yeah, you must be prepared for that. That's all. Yeah.
And again, as emphasized also by Migs here, you have, you have to determine, are we looking at activity or are we looking at damage? So as far as damage is concerned, can we ask, who wants to come first? Damage of pulmonary arterial hypertension in a patient with lupus, or is it inflammatory? In most cases of lupus, when you have pulmonary arterial hypertension in SLE, would you think more of inflammation or would you think more of damage, irreversible?
Not inflammation, but more of an obliterative vasculopathy, similar to what scleroderma can have. So anti-inflammatories are not part of the treatment paradigm for pulmonary hypertension, nor particular pulmonary arterial hypertension. I am fortunate enough that our institution at UCSF Fresno is one of the few PH centers in the nation. So it's really combined collaboration with cardiology, pulmonary, and rheumatology. And to lead up to that diagnosis as what needs to be focused on, among other needs of lupus, the specific treatment being available can extend their lives, and symptom and quality of life can be improved. My concern is that still the portion of ischemic workup, just to keep aware that less invasive strategies that can be done and hopefully can become available here is CAT scans, coronary calcium scoring, for example, to fully work up that it's not an ischemic nor concomitant ischemic cardiovascular disease in our patients with lupus who's at risk. And also cardiac MRI, where even if we do left heart cath and evaluate coronary vessels, microvascular disease won't be found. But myocardial inflammation, finer details on activity of lupus flare affecting heart structures, other modalities like CAT scan, cardiac MRI are available. And in that process also, the simpler tests, the monitoring and evaluative strategies like echo for this patient might already give us answers. That was 2021, the event. Postpartum cardiomyopathy would have resolved, and Takotsubo's cardiomyopathy could also be improved with that element of time alone and re-evaluating with even echocardiography. So obliterative vasculopathy in the sense of pulmonary hypertension, other than inflammatory mechanism is what I think for PH in lupus.
Okay, so a simple question now. If this patient had the onset of pulmonary arterial hypertension, diagnosed lupus in 2004, what if this patient presented with this kind of an increased pulmonary pressure in 2005, just a year after diagnosis? Would your treatment be different in terms of treating an inflammatory component here? And that will lead me to a related question. Would there be a difference in the prognosis of a scleroderma patient with pulmonary arterial hypertension versus a lupus patient with pulmonary arterial hypertension?
Definitely it would direct treatment strategies because the obliterative vasculopathy of PH, scleroderma, or lupus would not necessarily not respond to immunosuppressive therapies as the focus, which would be the difference in if lupus has their inflammatory flares beyond that manifestation, then they'd need both anti-inflammatory immunosuppression and selective treatment for PH, while scleroderma would have to focus on specific organ therapies like PH treatments as soon as possible for early focus treatments on PH, not necessarily anti-inflammatories or immunosuppressive unless they also have concomitant interstitial lung disease or other diseases that warrant immunosuppression.
Yeah. Okay. Question for each of you. 2005, pulmonary hypertension. Would you be more aggressive with steroids in this case if this patient had pulmonary hypertension in 2005? Leonid?
Yes. Yes, I would be aggressive because the onset and timing of the diagnosis plus the development of the pulmonary hypertension of the patient is very close to the diagnosis. So we more or less might have to control the other organ manifestations of the patient. Precisely the lupus nephritis that is present in 2004, and I would be more aggressive in terms of immunosuppression if this patient now has pulmonary arterial hypertension, while in addition to the lupus nephritis. We've had cases previously with lupus nephritis with pulmonary hypertension that greatly improved with immunosuppression. And so in these cases with active lupus nephritis and pulmonary hypertension, I would be very aggressive with treatment with immunosuppression and corticosteroids.
Okay, I guess that would also partly explain the question here. Would serologists and acute phase reactants help narrow the diagnosis, or at least give directions on whether you have more inflammation? Then definitely you'll increase in acute phase reactants, wherein you may benefit from the use of immunosuppressives, aggressive immunosuppressives. Although this patient now is 18 years of lupus, and it's only now that she presented with pulmonary hypertension. So you'd think more of less of the inflammation, more of the thromboembolic phenomenon. Okay, so as I said, I think we're going over time here, and then we can continue more with the discussions as we. There's a very important question here on hydroxychloroquine. Hydroxychloroquine for this patient. Will you initiate? If it is not been initiated, will you continue? Will it help? Will it be of benefit?
Definitely.
Even at this stage?
Yes, it's also because there might be other reasons for the cardiomyopathy. Otherwise, if still unexplained, I'd have to think of hydroxychloroquine cardiomyopathy and not be able to use it or proceed with biopsy just to resolve the issue. But hydroxychloroquine has also anti-thrombotic effects, benefits of lowering cholesterol, lowering blood sugar. It's highly protective, and as an immunomodulator rather than immunosuppressive, its utility for lupus, I think, is obligatory that we give it and be a background safe therapy, including if she decides to breastfeed or continue through her childbearing plans. That's also one thing we can use safely in pregnancy and lactation. So I wouldn't really consider not using it.
And you're all nodding your heads. Yes, you will all put in hydroxychloroquine, more likely to give more benefit rather than harm in this patient. And that is an adjunct therapy that we all know. And I think did it make you more confused in a way? Overwhelmed, maybe confused a bit, but overwhelmed with this because we're stretching out from the usual SLE patient. And there's actually one question here. Is the patient in lupus flare with this kind of a picture? Again, we were tossing that back and forth. So you have inflammation, you treat as flare. Okay, but are you doing damage now, Leonid?
It's always difficult when you have chronic patients having a new manifestation of supposedly yesterday, but when we look at it, we always do whether it's attributed to the activity of the disease or not. So we always, as Migs already said earlier, we have to exhaust the diagnostic here and find out what is causing the cardiomyopathy, what is causing the pulmonary arterial hypertension of this patient. Serologists will help, probably. Yes, if there are, if the test became equivocal, and if it's compatible in terms of the 2D echo, if it's compatible with the cardiomyopathy of lupus, then definitely it would be a supporting objective finding of having serologists in this patient. But we always look at the trending when we see that, look at the dsDNAs and the C3s of this patient. Probably this patient, if this chronically hypercholesterolemia and she's still hypercomplemenemic, would I attribute as an activity? So that's a question for clinicians as well, of looking at these parameters from the history of your patient, from the previous monitoring, because that will matter a lot in terms of deciding whether you should attribute that positivity or low complementemia in as an SLE activity.
Again, putting back your perspective on this case, if you look at the case again, it's a nagging question. In a patient who started off with lupus nephritis, diagnosed, no question, give induction, maintenance therapy, and she seemed to be okay. And then now, postpartum, you have proteinuria. So the question here in the proteinuria is, are we having lupus nephritis there? I mean, we had a lot of discussion about cardiac, pulmonary involvement in this patient. But what about the kidneys? So what's happening in this case? Why is this patient having 3+ proteinuria with a UPCR of 4.79? So Vince, would you have other reasons for the proteinuria other than the lupus flare?
Okay, so as we all know that albuminuria has long been recognized as an independent predictor of cardiovascular disease and outcomes in individuals with and without cardiovascular comorbidities. So it has been known that urinary albumin excretion, albuminuria, is proportional to systemic transvascular albumin leakiness, implying that it may reflect an underlying systemic manifestation of vascular dysfunction. So in two different cohorts of pulmonary arterial hypertension patients, albuminuria is associated with a poor outcome, and the absence of traditional risk factors suggests that other non-classic contributors to albuminuria, such as your systemic inflammation. And also, low-grade albuminuria is an emerging biomarker for the development and progression of systemic cardiovascular diseases. So these slides simply show that an increase in an urinary albumin creatinine ratio of more than 10 micrograms per milligrams was associated with an increased risk of poor outcome. And the last one is, what are the possible mechanisms in albuminuria in PAH? Actually, the first possible mechanism is the diastolic dysfunction and venous congestion in the left heart failure have been associated with altered glomerular hemodynamics and permeability, which can contribute to increased albuminuria. The other one is that systemic inflammation is also linked to urinary filtration, albumin excretion, which is known to be present in PAA patients. So increased urinary albumin creatinine ratio would also elevate your CRP, and it is always interesting to note that there is a weak but significant correlation between urinary albumin creatinine ratio and like for example hemoglobin A1C in PAH patients without diabetes, implying that insulin resistance could also be part of this process.
So, the question here, short question for each of our panelists. For this patient with your proteinuria, recent onset, new onset, Is it lupus? And you would, when you say lupus nephritis flare, would you treat with high dose steroids or immunosuppressive agents, as we know in lupus, immunosuppressive at this point? Yes or no? Leonid? Leonid? Okay. Whoever has a working microphone first and can talk first.
I think it's technically maybe not glomerulonephritis like class 3 or 4, but nephrotic syndrome can present that way with proteinuria and need high aggressive immunosuppression. And the low albumin, hypercoagulable state might also tie in and potentially support nephrotic syndrome, whether it's a change in the manifestation of our lupus nephritis, or it's a different process where focal segmental glomerulosclerosis can also present similarly. I think high dose steroids at the very least, while also addressing the pulmonary hypertension and possibly a nephrotic like syndrome explaining the renal high significant proteinuria.
Okay. Dr.
I
Lani?
think, yes, I think renal biopsy is warranted for this big case.
Okay. Leonid? Yes, microphone.
Very important in this case, as we're trying to determine if this is really an SLE-related
You were looking at the kidney biopsy.
Yes.
Okay,
I
you'd
said
like
I
a
would
kidney
agree.
biopsy. Would the intensivist allow a kidney biopsy at this point? Will that take priority?
Well, Doctor, of course we would allow as long as the patient is hemodynamically stable. And that's where the hemodynamic monitoring that we do in the ICU.
So what if a
comes into
biopsy
play.
cannot be done? This patient is on low molecular weight heparin. This patient is in a prothrombotic state. You cannot remove the medications. Would you still go for a biopsy, or would you go for empiric immunosuppressive treatment?
That's a difficult question to answer in this case.
Sorry, I'm putting you on the spot.
Okay, so we have the risk factors for a prothrombotic event to happen. You have the erythrocytosis here, you have an SLE patient, you have a peripartum or postpartum patient. So if the patient is already anticoagulated, I would continue on anticoagulation and just monitor this patient's urinalysis and kidney function. Now, whether there would be changes in the urinalysis and even in the kidney function of this patient, then I would proceed with probably trying to do an empiric immunosuppression.
So you will prioritize on your prothrombotic state, hypercoagulable state in this patient. That's your priority at this point?
In my opinion, Doctora, in an ideal setting where, let's say, cost is not an issue, I would have to agree that we should do all the workup in order to really differentiate one disease entity from the other. But from our experience, most of the time we're left with just the clinical eye, and Dr. Navarra has a very outstanding clinical eye. Sometimes I think as long as the patient understands the risks and the benefits of giving the empiric treatment, I would probably give both the empiric and the supportive treatment for all the other problems that this patient has.
So again, back to my question, will you give this patient empiric immunosuppressive? Vince has already mentioned that your proteinuria may not necessarily be due to your glomerulonephritis.
It could be from a lot of things, but like I mentioned, from what I remember back in fellowship, sometimes since the patients do not have the financial capacity to do all the tests, sometimes we're left to be clinicians, right, Doctor? That's what you were teaching us. Be good clinicians, so that sometimes you just try to tie all of these things together and come up with good decision on whether to treat this patient as a possible lupus flare, and then maybe treat both. Treat both. Treat all the
Okay.
conditions.
Yeah. So again, it's whoever is there, and we have the luxury of seeing the patient. So which you do not have, and you're seeing this only from the discussion. But any response is correct, as long as it is, what are your priorities in this patient? You agree with that, Lani and Candice, yes? Okay, so, okay, so there are no more questions for this time. And I'd like to wrap this up. I am sure you're overwhelmed with this case. You've seen how our panelists have discussed the case from different points of view. You've seen that they may not necessarily agree on one point, but agree on most points. But we all agree this is not the end of the road, because we will need to understand more of these patients. It's not what you see is what you get in these patients. These patients can give you actually more questions than answers, and that is how it is with this patient. But nonetheless, I hope that the last 1 hour or so provides us with additional learnings from this intriguing, actual, real-world experience in this patient with lupus nephritis, cardiomyopathy, presenting with new onset cardiomyopathy, postpartum at that, and then pulmonary arterial hypertension, and of course, new onset again of your proteinuria in this patient. Polycythemia, as we discussed, is more likely secondary, but contributory as well to the hypercoagulable state. So here we have discussed also how to make a differentiation between peripartum cardiomyopathy versus flare, pulmonary arterial hypertension a little more extensively in terms of the mechanisms. Is it inflammatory or is it thromboembolic? And of course, the management, or the management, because these patients are a whopping 91 millimeters mercury, severe pulmonary hypertension. And of course, discuss also on the proteinuria, which we always assume as lupus nephritis, but forget about the fact that this patient has underlying reasons for proteinuria or albuminuria other than just inflammatory. So again, with that, let me thank our panelists. Let me thank our presenter, Vince. Good job, Vince. Thank you. And our fellows also who helped prepare the case. We'd like to thank Dr. Leonid Zamora, as always, for that. And Candice for giving us a perspective that you would have from the other part of the Pacific. And we have Dr. Hamid Joyo. Thank you so much for experiencing your cases. And we have, of course, our rheumatologist intensivist who has shown us that, with lupus, you need to be holistic here, and you need to keep learning, keep training on this. Again, thank you very much for that. And thank you, everyone for your participation and your questions.
Indeed, a difficult and compelling case. Thank you so much to our distinguished panel for sharing your expertise. With this, we request the doctors to please join us down here and receive the award, your certificates and tokens of appreciation from Doctors Rosario Baez and Michael Gomez. Thank you so much to our chairperson, Dr. Annette Raso. And of course, Dr. Sandra Navarra. Our case presenter, Dr. Vincent Lucenio. Our panelists, Dr. Laniyati Hamijoyo, Dr. Ramon Miguel Molina, Dr. Candice Marie Reyes, and Dr. Leonid Zamora.